So I will start immediately. Inshallah, today I will cover a lot of thyroid guidelines, especially guidelines related to European board examination and subspecialty examination. Um, so as I say every time, tools, files, and videos are not for redistribution. And also this is interactive presentation, so I hope from everyone, if anyone want any question, please stop me and ask what you need to talk, or if you want to do any comment. Today, inshallah, I will cover a lot of guidelines, specifically in nice guidelines related to the thyroid. European Thyroid Association guidelines, Society of Endocrinology guideline, EGOGO guideline, and the British Thyroid Association guideline related to the thyroid cancer, which is published in 2014. And actually, we have a lot of guidelines, and today, inshallah, I will cover about 16 guidelines. So I will cover all of this recommendation except this guideline published by EGOGO and European Thyroid Association about the management of Graves' orbitopathy, and because there is update in 2021, so I will cover the updated guidelines. Another one I will not cover today, inshallah, 2020 European Thyroid Association guidelines about the use of image guided ablation in benign thyroid nodule. And actually, these guidelines I previously present non-surgical management of benign thyroid nodule, and I already covered this guideline. And another one which I will not cover today, inshallah, evidence based use of levothyroxine liothyroid combination in treating hypothyroidism, because this is evidence-based guidelines, a lot of sophisticated evidence and basic medical confusing science. And today I will cover the combination therapy guideline, which is published in 2012. And also, I will not cover the use of minimal invasive treatment in malignant thyroid lesions, and also consensus statement what are the indication for post-surgical radio iodine therapy in differentiated thyroid cancer. But most of them I will cover in when I cover British Thyroid Association guidelines on the management of thyroid cancer. And actually, this collection I will already upload it for whom who subscribe with me in this paid course. A PDF file contains this all guidelines, and inshallah later I can upload one with which is highlighted. Wa alaikum assalam wa barakatuh. So I will start immediately by one of the most important guidelines, nice guidelines for thyroid disease assessment and management, and this already published in November 2019. The goal of treatment of any thyroid disorder is to alleviate symptoms and align thyroid function test if abnormally within or close to the reference range. So we need to improve the symptoms, and also normalization of thyroid function test if it is abnormal. Even when there are no symptoms, for example, subclinical hypothyroidism or subclinical hyperthyroidism, this is usually a mild thyroid disorders. The treatment may be advised to reduce the risk of long-term complications. As all of us know that subclinical hyperthyroidism, a risk of osteoporosis, a risk of cardiac arrhythmia increase, especially in the elderly patient. In this situation, we treat subclinical hyperthyroidism to reduce long-term complications. we should know that symptoms may lag behind the treatment change for several weeks to months. So some cases of hypothyroidism, even after normalization of the TSH, the patient may be still symptomatized. So symptoms may lag behind the treatment change for several weeks to months, and this actually is different from disease to another one. Day-to-day change in unexplained symptoms are unlikely. So most cases of thyroid disorders, symptoms will not change rapidly and not will improve rapidly. So this is very important when you deal with a patient with hypo or hyperthyroidism. Investigation for the patient suspected with thyroid dysfunction or thyroid enlargement. What is the indication for test? Whom to screen? Actually, there is no recommendation about screening, but we should respect our clinical suspicions of thyroid disease. This is the most important to whom to investigate. Also, we should know that one symptom alone may not be indicative of thyroid disease. But actually, all recommendation or guidelines recommend any patient with type 1 diabetes, we should screen for thyroid disorders annually. Also, we should screen if any patient have autoimmune disease. And another recommendation for initiation of testing is a patient presented by new onset AF. So we have three patients we should screen: type 1 diabetes annually, autoimmune disease annually, new onset AF. But in another cases, we can consider testing for thyroid dysfunction. For example, if the patient presented by unexplained depression or unexplained anxiety, in this situation, we recommend screening. Also, it is we should consider testing for thyroid function in any child or young people with abnormal growth, as we know that hypothyroidism causing short stature, or any patient with unexplained change in the behavior or school performance. In this situation, we need to screen for thyroid dysfunction. Don't test for thyroid dysfunction during an acute illness, because as we know that there is a non-thyroidal illness which will be presented by abnormal thyroid function test. T3 will be low, T4 will be low, TSH will be low, normal or low. In this situation, it can be confused you as a diagnosis of central hypothyroidism. In this situation, all guidelines recommend don't screen for thyroid function test in acutely ill patient, except if you have a very high suspicion of hypothyroidism or myxedema, coma, or thyrotoxic crisis. Also, for type 2 diabetes, don't offer testing for thyroid dysfunction because the patient is type 2 diabetes alone. But if there is another manifestation of thyroid dysfunction with type 2 diabetes, we should screen. So type 1 diabetes, we should screen for thyroid dysfunction yearly, but type 2 diabetes is not recommended, except if there is a manifestation of thyroid disease. How to do the testing? Tests when thyroid dysfunction is suspected. Please consider measuring TSH alone. Thyroid hormone, thyroid autoantibody is not recommended as a first choice to save your patient's money. Please do TSH alone. If TSH is above the reference rate, so the patient is hypothyroid, in this situation, we should measure free thyroxine, free T4 in the same sample. If TSH is low, so the patient is thyrotoxic, in this situation, I will do free T4 with free T3. So this is a very important hint about which test to start with. So the TSH is the gold standard test for thyroid of primary thyroid dysfunction. If TSH is normal, this will exclude the primary thyroid dysfunction 100%. If TSH is hypothyroid, if TSH is elevated, the second one is a free T4, no need for T3. If TSH is low, so the patient is thyrotoxic. The next step is doing free T4 and free T3 or total T3. Why combined free T4 and T3? To exclude T3 thyrotoxicosis, in which TSH will be low with normal free T4 with elevation of the free T3 or total T3. So this is a T3 thyrotoxicosis. We need not to miss T3 thyrotoxicosis. But the guideline recommend measuring both TSH and free T4 in two situations. If you suspect secondary thyroid dysfunction, like for example central hypothyroidism, in this situation we should do TSH with free T4, because in central hypothyroidism free T4 will be low with normal TSH or mildly low TSH, and in some cases TSH may be elevated, mildly elevated TSH, similar to overt hypothyroidism. And in another situation, we should measure TSH plus free T4 children and young people, as we will discuss later, inshallah. Consider repeating the test only if symptoms worsen or new symptom develop. But don't forget that repeating test should not be sooner than 6 weeks from the most recent test. Please don't repeat thyroid function test except after 6 weeks from the last one, even if new symptoms are appeared. But the only exception for this, if the labs is not not sure that the labs are right, or you suspect, for example, thyroid function test assay interference. In this situation, I will repeat this test. How to manage? Managing primary hypothyroidism. How to test for people with confirmed primary hypothyroidism. In this situation, TSH will be elevated with normal free T4. This is a subclinical hypothyroidism, or low free T4. In this situation, overt hypothyroidism. For adults, we should do TBO antibody, microsomal antibody, or anti-thyroid peroxidase antibody for adults with a TSH level above the reference range. And this is very important. No need for repeating TBO testing. This is very important because we see in our clinics a lot of physicians repeating a TBO antibody every month or every 2 months. For what? This is just a cost. So the guidelines recommend don't repeat TBO antibody testing. The exception for repeating TBO antibody testing for children and in young adults. For children and in young adults, the guidelines recommend measurement of TBO for children and TSH, and possible repeat TBO antibody testing at the time of transition to adult surfaces. So this is the only exception for repeating TBO antibody. وعليكم السلام ورحمة الله وبركاته Dr. Muhammad. So this is very important when to order TSH or another thyroid hormone, and also when doing TBO antibody. So a TBO antibody must be ordered or considered if TSH is elevated, and don't repeat it. We can repeat it, possible repeat TBO antibody for children at the time of transition to adult surfaces. How to manage? Actually, levothyroxine is the first line management, is the first line treatment, and don't routinely offer liosayronine, cytomel. Don't offer natural thyroid extract. So the only treatment recommended for primary hypothyroidism is levothyroxine. And later on, inshallah, I will cover a combination of liosayronine plus levothyroxine for specific situations and how to do this combination. Why, Dr. Aranda? Why? Why what?
Why to measure TBO at transition from childhood to adult surface?
This is a possible
what is the
recommendation
benefit?
because in some cases, actually, and I will cover it later in another slide. A TPO antibody titer which is positive may be weaned with time. This is recorded in some cases. And also it may be if TSH is elevated may be positive in the early stage may be negative and later on may be positive, so it is recommended to be measured during a transitional period, not routinely every year. But actually for type 1 diabetes, the
What is
American Diabetes Association recommend measuring TSH and anti-TPO yearly if it is negative. So if TSH is normal with anti-TPO is negative, in this situation, it is recommended by American Diabetes Association to repeat it every year. But if TSH is elevated, TPO is not repeating routinely except in this situation. Consider starting levothyroxine at a dosage. So in every patient with hypothyroidism, especially overt hypothyroidism, I will start by 1.6 microgram per kilogram per day body weight. This is rounded to the nearest 25 microgram for adults under 65 years with no history of cardiovascular disease. So I will calculate the total daily dose and the patient can start by it. Exception for these two situations: if the patient is elderly, adult age more than 65 years or over, or patient with history of cardiovascular disease. In this situation, we should start by small dose, 25 to 50 microgram per day with titration, and I will increase the dosage after 2 to 3 weeks later on. The upper limit of the TSH is different according to the age. Actually, in most adults, the upper limit of the reference range is about 4.2. In some labs, it is 5, but in children, it is related to the age. In a newly born, it may be reached about 20, and in some situations later on, it may be 9 or 7 according to the age. So we should respect the reference range by the lab. How to follow up and monitor a patient with primary hypothyroidism? Actually, test for follow up and monitoring of primary hypothyroidism. Usually we follow up by TSH level. Our aim is to maintain TSH level within the reference range. Exception, of course, for a pregnant female, the target of the TSH is less than 2.5. And actually, this can be elevated to be less than 4, if especially if TPO antibody is negative. In this situation, we can accept TSH as 4 in pregnant female. And this is according to the American Thyroid Association latest guidelines for management of thyroid disorder during pregnancy and postpartum. Be aware that a TSH level can take up to 6 months to return to the reference range for people who have a very high TSH level. But actually, this is in clinical practice is not very common. Most cases of primary hypothyroidism, once you treat by a full dose of thyroxine, within 2 months, TSH will be normalized. But for TSH suppression in Graves of thyrotoxicosis or Graves disease, the recovery of the TSH need very long duration, about 6 months or more. Yes, Dr. Mahmoud Al-Khatib, in elderly, and I will cover this later, inshallah. In the elderly, if TSH is very high, as for example 65, we should start by low dose of thyroxine and titrate it according to every 2 to 3 weeks up to reach the target dose. And actually, the target dose of in the elderly is less than the young one. For example, the full replacement dose in the elderly is 1.6 microgram per kilogram per day. But for the elderly, most of the elderly require dose less than this, about 1.4 But actually in the elderly, I start by low dose, increase the dose after 2 to 3 weeks, and assess by TSH after 6 to 8 weeks of duration. So this is very important, how to manage subclinical and overt hypothyroidism in elderly, and I will cover it in the guidelines published by the ETA for the management of subclinical hypothyroidism.
Dr. Khalid,
Yes.
which guideline you are explaining right now? As I
This
enter
is
the
a nice
case.
guidelines. This is a nice guidelines published in 2019. This is the latest guidelines about the thyroid diseases published by the NICE, which is very important and essential guidelines for subspecialty examination and European board examination. Yes, elderly means 65 or 70, 65 to 70 or more age. So this is elderly according to the guideline. Actually, European Thyroid Association in the previous guidelines mentions that the elderly more than 65, but in the latest one mentioned if more than 70, and in some situations they mention that elderly 65 to 70 or more. So we should respect this age. Yes, regarding TBO, is it positive or negative? It will be different in the management. Yes, yes, Dr. Amy. Actually, and I will cover this later on when I will discuss when to treat subclinical hypothyroidism, especially subclinical hypothyroidism. Overt hypothyroidism, the anti-TBO has no rule in management of in overt hypothyroidism. If it is elevated with low free T4, all recommendation we should treat. But if it TSH is elevated with normal free T4, in this situation, this is a subclinical hypothyroidism. When to treat? One of its indication to treat if the anti-TBO is positive. We should treat even if it TSH is less than 10. But if it TSH is more than 10, we treat irrespective of anti-TBO or free T4. This will be covered later on. How to follow a patient with a primary? Yes. Yes.
You read the statements of
Is a
guidelines and all the.
repeat, Dr.
Khalid,
Mahawish? Yes.
Dr. Khalid, you read the statements of guidelines and text of endocrinology of experts. When you explain it in your own words, it becomes more easy. After reading the lines, can you explain it in?
Actually, your voice, Dr. Mahawish, is increased and decreased, so I cannot listen to your voice. No voice.
Hello?
Yes.
Dr. Khalid, when you read the statements of text.
Yes, I read the statement and just give some of comments.
Dr. Khalid, when you explain your own words, then it's become more easy to grasp. Hello?
The voice is interrupted, Dr. Mahawish.
I write in chat books.
If you can write it, Dr. Mahawish, because the voice is not clear enough. So how to follow our patient? If adults, we should do TSH every 3 months until the level has stabilized, not earlier than this. And actually in clinical practice, we do TSH after 6 to 8 weeks according to the American recommendation. But the British recommendation consider TSH measurement during the follow-up of patient with hypothyroidism after 3 months until the level has stabilized. How to know the level is stabilized? By doing 2 similar measurements within the reference range 3 months apart. In this situation, we should follow up by repeating TSH every year. Consider free T4 as well as TSH for adults who continue to have symptom hypothyroidism after starting levothyroxine. In this situation, we should follow by doing TSH and free T4. But for children and young people aged 2 years and over, in this situation, we should measure free T4 and TSH every 6 to 12 weeks until the TSH has been stabilized. Later on, we should doing TSH every 4 to 6 months until after puberty, and then once a year as adults. For children less than 2 years, in this situation, we should measure free T4 and TSH, both labs, and we should follow every 4 to 8 weeks until the TSH has been stabilized. Then every 2 to 3 months during the first year of the life, and then every 3 to 4 months during the second year. And this is actually is very important to follow up a patient, either adult or children under 2 years of age. How to follow up when doing TSH and when doing TSH and the free T4, which is essential in clinical practice. Yes, Dr. Mahawish, okay. So how to manage and monitor subclinical hypothyroidism? As I mentioned the previous, subclinical hypothyroidism means TSH is elevated, then a reference range for this patient and age with normally free T4, no rule 43. For adults, we should consider measuring a TBO antibody for adult with TSH above the reference range, and don't repeat TBO antibody. When to treat, this is a very important. If the patient is symptomatized, symptoms of hypothyroidism, or there is a previous radioactive iodine ablation or thyroid surgery, or raised level of the thyroid autoantibody. So this is the indication when to treat subclinical hypothyroidism. If there is a symptoms or a previous history of radioactive iodine ablation treatment or thyroid surgery, for example, the patient doing lobectomy, or there is a positive anti-TBO. And this is one of the indication of anti-TBO to decide whom to manage in subclinical hypothyroidism. Consider levothyroxine in adults if TSH is more than 10. So when to treat a patient with subclinical hypothyroidism if TSH is more than 10, if the patient is symptomatized, if there is a previous history of radioactive iodine or thyroid surgery, if there is positive anti-TBO. This is apart from pregnancy or infertility. Consider a 6-month trial of levothyroxine for adults less than 65 years if TSH is more than reference range but less than 10 with symptoms of hypothyroidism. But in this situation, if symptoms is not improved, I will stop levothyroxine. So this is a trial. This is a trial of a treatment for 6 months. And this is very important to normalization of the TSH. Because if TSH is still elevated, we should assess a response to treatment after 6 months of normalization of the TSH. If symptoms persist when serum TSH is within the reference range, I will stop levothyroxine. For children, this is different. When to treat subclinical hypothyroidism in children is different than adults. Consider levothyroxine if TSH is more than 20, this is important, or if TSH is more than 10 to 20 on 2 separate occasions, 3 months apart. So we should reassess TSH after 3 months if TSH is more than 10 and less than 20 for children and young adults. If TSH between 5 and 10, in this situation, I should repeat it after 3 months, and I will treat if there is a thyroid dysgenesis or signs or symptoms of thyroid dysfunction. So how to manage subclinical hypothyroidism in children is different than in adults. In adults, we can treat if TSH is more than 10 alone. One reading of TSH is more than 10, I will manage it. But for children, we can manage if TSH is more than 20, if TSH between 10 and 20 on 2 separate occasions 3 months apart, or TSH is less than 10 with thyroid agenesis, dysgenesis, or signs of symptoms of thyroid dysfunction. And for children less than 2, I will treat if TSH is more than 10 or higher, because it may affect cognitive dysfunction. So this is very important. So children under 2 years, with subclinical hypothyroidism, I will treat if TSH is more than 10 according to the NICE guidelines. How to monitor a patient of subclinical hypothyroidism and not treated? For adult, I will measure TSH and free T4 once a year. If they have features suggestive of underlying thyroid disease or a previous thyroid surgery or raised level of thyroid autoantibody. If you decide your patient will need no treatment, I will repeat free T4 and TSH once a year if he have a positive anti-TBO or a feature of suggestive thyroid underlying thyroid pathology or previous thyroid surgery. But I will repeat TSH and free T4 after 2 to 3 years if no previous feature is presented. So this is for patient untreated subclinical hypothyroidism. How to monitor? So repeating of the TSH after 1 year at least, and after 2 to 3 years if anti-TBO autoantibody TBO antibody is negative.
Sorry, Dr. Khaled, regarding this
Young
point,
adults,
one question.
yes.
Regarding this point, if
Yes.
this patient previous radioiodine or previous surgery has TSH from 4 to 10, we will give treatment and the follow-up.
Yes, but in this situation, I will give a treatment, but after 6 months, if the patient is not responding, symptoms is not improved, in this situation, I can stop treatment. And in this situation, I will repeat TSH and FT4 because some of those patients may be transferred from subclinical hypothyroidism to overt hypothyroidism, and in this situation, I will treat. And actually also some patients of subclinical hypothyroidism may choose not to treat by levothyroxine. In this situation, I will repeat after 1 year, even if the patient is doing previous thyroid surgery or radioactive iodine ablation or anti-TBO antibody.
Okay, thank you.
Dr. Dorina asked if TSH is higher on one occasion and on the next appointment normal, should we follow this patient again? Actually, yes. But in this situation, I will do, for example, anti-TBO. I will doing thyroid sonography. If the thyroid architecture is abnormal, this patient should be reassessed again. But if underlying thyroid pathology, thyroid tissue is normal with negative anti-TBO, in this situation, I will repeat TSH after at least 1 year, not year than that. For children and young people who not to treated by levothyroxine and presented with subclinical hypothyroidism, in this situation, we should repeat TSH and free T4 every 3 to 6 months. If they have feature suggesting underlying thyroid pathology or thyroid agenesis. And we should repeat TSH and free T4 every 6 to 12 months if they have no feature suggesting underlying thyroid disease. And consider TSH and free T4 every 1 to 3 months for children less than 2 years with untreated subclinical hypothyroidism. So for younger people, I should follow up repeatedly more than adults. How to manage thyrotoxicosis? Actually, testing for people with confirmed thyrotoxicosis according to the guidelines, if we cannot differentiate, and this is very important, thyrotoxicosis or hyperthyroidism per se is not a final diagnosis. We should search for the etiology because the management is different according to the underlying etiology of thyrotoxicosis. So if we cannot differentiate between different types of thyrotoxicosis, in this situation, the guidelines recommend measurement of TSH receptor antibody, which is confirmed Graves' disease. Another one, we can consider technetium scan for thyroid gland if TSH receptor antibody are negative or not available. But thyroid sonography is not recommended routinely except if they have palpable thyroid nodule. This for thyrotoxicosis. So thyroid sonography is not recommended routinely in a case of thyrotoxicosis. Exception if you suspect a thyroid nodule. In this situation, thyroid sonography is very important to doing risk stratification of thyroid nodule.
We do ultrasound before or thyroid scan?
No difference. If you see thyroid nodule, I will do, and the TSH is low, the patient is thyrotoxic. In this situation, I will do thyroid scan and thyroid sonography, which is the first. Thyroid sonography is more available, so it is easily to be doing thyroid sonor. But in this situation, thyroid scan will differentiate doing fine needle aspiration biopsy or the patient presented by toxic nodule. So how to differentiate between toxic adenoma versus non-toxic adenoma or cold nodule? This is done by thyroid scan, technetium scan, or radioactive iodine. If hot nodule, in this situation, this is a toxic adenoma. No need to do fine needle aspiration biopsy. And in this situation, the patient is treated by antithyroid medication until definitive therapy by radioactive iodine ablation or surgery.
Right, doctor. In exam, we choose which one before ultrasound or
If TSH is low, the next step is thyroid scan.
Scan, yeah.
Oh, if TSH is low, the next step is thyroid scan. But practically, if TSH is low and the thyroid nodule is less than 2 centimeter, no need to do thyroid scan. And I will cover it in management of Graves' disease, the guidelines published by the ETA in 2018. I will cover this point because it is mentioned in the guidelines actually. For children and young people, differentiation between thyrotoxicosis and hyperthyroidism, we should doing TPO antibody and TSH receptor antibody. The TSH receptor antibody or TRAB is specific to Graves' disease, but TPO is not specific to any thyroid disorders. Maybe it is with autoimmune thyroid disease, actually Hashimoto thyroiditis, postpartum thyroiditis, atrophic thyroiditis. It is just a marker for autoimmune thyroid disease, not specific to specific disease. Consider technetium scan of the thyroid gland if TSH receptor antibody are negative, and this is the recommendation by NICE. Only offer thyroid sonography if they have a palpable thyroid nodule or the cause of thyrotoxicosis remains unclear following thyroid autoantibody testing and technetium scan. In this situation, we should doing thyroid sonography. Is my voice clear?
Yes, doctor, clear.
Okay.
Yes.
How to treat a patient with in primary non-specialized care? The guidelines recommend be aware that transient thyrotoxicosis without hyperthyroidism usually only needs supportive treatment. For example, beta blocker for a tremor and palpitation or tachycardia. Consider antithyroid drug along with supportive treatment for adults with hyperthyroidism who are waiting for specialized assessment and further treatment if this needs a long duration. In this situation, we can start by anti-thyroid medication. Dr. Sadeh asked, is it the plain ultrasonography or with a flow Doppler? Actually, most accurate flow Doppler sonography. And this is the most one of the methods to differentiate between Graves' disease and thyroiditis, Doppler sonography. But the accuracy of it depends on mainly on the operator. Adult with Graves' disease. So the etiology of thyrotoxicosis Graves' disease, how to manage? Actually, the guidelines recommend radioactive iodine as a first line definitive treatment for adult with Graves' disease unless antithyroid drugs are likely to achieve remission. And actually, this is changed in the previous series. Previous than 2019, all recommendation are to start with antithyroid medication. But later on, like American recommendation, radioactive iodine has a first choice in most of cases, except if the patient will remit. The risk of remission is high with antithyroid drug. This is the only, not the only, this is the most indication to start with antithyroid drug. Or in this situation, if radioactive iodine is not unsuitable, in this situation we can start by another modality. For example, if the patient presents by thyrotoxicosis or Graves' disease with compression manifestation, with suspicious of malignancy, or a pregnant female or trying to become pregnant within the 4 to 6 months, in this situation, radioactive iodine is not suitable. Or a patient presented with active thyroid eye disease. Don't forget active thyroid eye disease, because inactive thyroid eye disease can be received radioactive iodine without any problem. So the guidelines recommend radioactive iodine as a first line definitive treatment for Graves' disease unless antithyroid drugs are likely to achieve remission, and this will be covered later. Or it is unsuitable. Offer a choice of antithyroid drug or radioactive iodine as a first choice for adults with Graves' disease if antithyroid drugs are likely to achieve remission, for example, mild and uncomplicated Graves' disease. Doctor may ask about the difference between hyperthyroidism and thyrotoxicosis. Hyperthyroidism mainly increases thyroid hormone for any reason. For example, a patient received thyroxine from oral thyroxine. This is a case of thyrotoxicosis. Patient presented by abnormal thyroid tissue in any site of the body, for example, teratoma. In this situation, this is a thyrotoxicosis. But hyperthyroidism only increase its senses of thyroid hormone endogenously, like Graves' disease, like toxic adenoma. But actually, in clinical practice, hyperthyroidism and thyrotoxicosis usually is changeable terms. Most of us say thyrotoxicosis for all patients presented by low TSH with elevated thyroid hormone, and also the hyperthyroidism the same. But actually, hyperthyroidism only the term represent increase endogenous thyroid hormone senses and secretion. For example, Hashimoto's thyroiditis can be presented early by destructive thyroiditis. TSH will be low with elevation of thyroid hormone. This is not hyperthyroidism. This is a thyrotoxicosis because no elevation of thyroid hormone senses and secretion. It is a destructive thyroiditis. This is a case of thyrotoxicosis, not hyperthyroidism. Is it important to in hypothyroidism to perform an anti-TPO? Actually, not in most cases, Dr. Ashraf. If TSH is more than 10 or overt hypothyroidism, in this situation, anti-TPO has no value, no additive value. But actually, anti-TPO, the main value of it is to determine the etiology of hypothyroidism. If the anti-TPO is positive in this situation, this is a case mostly Hashimoto's thyroiditis. But if it is negative, I should search for another cause of hypothyroidism. but the treatment is not different except if TSH is less than 10. In this situation, if anti-TB is positive, this I will treat. Oral antithyroid drugs as a first-line definitive treatment for adults with grave disease if radioactive iodine or surgery are unsuitable. Which type of surgery? The recommendation for grave disease, total thyroidectomy as a first-line definitive treatment, especially if the patient presented with compression or this is suspicious of malignancy or radioactive iodine and antithyroid drug are unsuitable. So usually radioactive iodine is the first choice except in some situation in which antithyroid drug are remission is high. A thyroidectomy is the last option, but a total thyroidectomy may be the first option if there is a compression, if there is a suspicion of malignancy, if there is a contraindication to radioactive iodine or antithyroid drug. Consider radioactive iodine or surgery for adults with grave disease who have had antithyroid drug but have persistent or relapsed hyperthyroidism. So, in any case of relapse of a grave disease or persistent of a grave disease after 1 or 2 years of treatment with antithyroid drug, in this situation, we should consider radioactive iodine or surgery as a definitive treatment. And this will be covered, inshallah, in the guidelines of a grave disease. Adult with toxic nodule, the first line therapy for toxic adenoma is radioactive iodine, unless it is unsuitable. In this situation, surgery is the next one. Offer total thyroidectomy or lifelong antithyroid drug as a first line definitive treatment for adults with hyperthyroidism secondary to multiple nodule, toxic nodule, if radioiodine is unsuitable. If a radioactive iodine is unsuitable, surgery, hemithyroidectomy should be the first line definitive treatment for adults with hyperthyroidism secondary to single nodule, hemithyroidectomy. Or the alternative of surgery is lifelong antithyroid drug if this option are unsuitable. For children, antithyroid drug should be the first choice for at least 2 years and possible longer. European Thyroid Association in the guidelines, they mention that the duration of antithyroid drug for children is 36 months, 3 years. But in NICE guidelines recommend the antithyroid drug for children for at least 2 years. Consider continuing or restarting the antithyroid drug or discussing radioactive iodine or surgery if relapsed hyperthyroidism in children. So, and I will cover it later on, in case of grave relapse in children, we should consider or continue or restarting antithyroid drugs. This is one option. Another one, radioactive iodine ablation or surgery. But actually, continuing the antithyroid drug will not cause remission, even after long more than the previous duration. In this situation, Dr. Shavan asked in exam which to write, 2 years or 36 months. If the question, actually in the exam they will not mention a confusing question like this, but in subspecialty exam I will choose at least 2 years. But in European board I will choose 36 months like European Thyroid Association. For children and young people with hyperthyroidism secondary to single or multiple nodule, antithyroid drug should be used using titration regimen of carbimazole to prepare your patient for surgery or radioactive iodine. Antithyroid drug for adults, children, and young adults with hyperthyroidism. How to follow up and how to start. Before starting antithyroid drug, we should check CBC and liver function test. This is before starting antithyroid drug. if we start الانتي drug duration at least 12 to 18 months for adults using both regimen, a block and replace regimen or titration regimen. A block and replace regimen, we start by a very high dose of carbimazole combined with thyroxine. And titration regimen, we start by a high dose of carbimazole and then reduce the dose according to the response. When offering an anti-thyroid drug to children and young adults with Graves' disease, offer carbimazole using a titration regimen and review the need for treatment every 2 years. So, for children, block and replacement regimen is not suitable. We should start with carbimazole, not propylcyracil in children and adults. So, usually start with carbimazole. For adults, children, elderly, all people should start with carbimazole except two situations, and I will cover it later. Offering a lifelong anti-thyroid drug to adults with hyperthyroidism secondary to toxic adenoma, consider treatment with a titration regimen of carbimazole if the patient refuses surgery or radioactive iodine. Young adults, here they mentioned the young adults till the age of 16 or 18. Consider propylcyracil only for adults who experience adverse reaction to carbimazole, like severe urticaria or severe itching. In this situation, we can give him propylcyracil if not responding to antihistaminic. Who are pregnant or trying to become pregnant within the following 6 months, history of pancreatitis. This is the only three indication in a patient with Graves' disease in which you should start propylcyracil. Experience adverse reaction to carbimazole, pregnant or trying to be pregnant within the following 6 months, history of pancreatitis. Please stop and don't restore any anti-thyroid drug if a person develops a granulocytosis. A granulocytosis means a granulocyte less than 500. If you suspect a patient with granulocytosis, you should stop anti-thyroid drug and doing differentiated blood count. If a granulocyte is less than 500, this is a case of granulocytosis. This is a fatal condition if you restart the anti-thyroid drug. In this situation, I will go to the radioactive iodine ablation or surgery. Because the carbimazole increases the risk of pancreatitis. Dr. Arand asked why carbimazole contraindicated pancreatitis, because it increases the risk of pancreatitis more than propylcyracil. How to follow up and monitor a patient with hyperthyroidism? Actually, we should consider measurement of TSH, free T4 and free T3 level in adults, children, young adults, every 6 weeks for the first 6 months until a normalization of the TSH. In this situation, I will follow by TSH. Suppression take a very long duration until normalization. So we titrated dose of carbimazole according to the free T4 and the free T3. And actually, I cover these points clearly in previous presentation in ThyroAlex about the medical management of Graves' disease. By carbimazole, Dr. Muhammad, how can I treat Graves' disease in lactating female by carbimazole? Carbimazole is the only approved drug for management of Graves' disease except in the 3 situations. In this situation, I will start by propylcyracil. Side effect of carbimazole: first trimester or patient need to be pregnant within the 6 months, a patient with a history of pancreatitis. Otherwise, carbimazole is the only available medication. Why? Because the propylcyracil have a very fatal side effect causing acute liver cell failure. Fatal liver cell failure. So, propylcyracil is not approved except for these few situations. For adult children and young people who have hypothyroidism after radioactive iodine treatment and are not on antithyroid drug, offer levothyroxine replacement therapy. And this is very important actually in clinical practice. If any patient already on antithyroid drug and they presented by hypothyroidism, please reduce or stop the antithyroid drug, not to give levothyroxine. I will start by levothyroxine if the patient already not on antithyroid medication. This is a case of epidemic hypothyroidism if the patient on antithyroid drugs and presented by elevated TSH. For adult children and young adults with a TSH in the reference range 6 months after radioactive iodine, please consider measuring a TSH alone at 9 and 12 months after treatment. If the patient is hypothyroidism, I will start by levothyroxine. Two situations for pylcyracil actually. If there is a granulocytosis but more than 500, actually, Dr. Aranda, a granulocytosis means a granulocyte less than 500. If granulocyte is more than 500, this is not a case of a granulocytosis, and we can continue carbimazole. We can restart carbimazole or even propylcyracil if indicated. So a granulocytosis is a fatal condition, means a granulocyte is less than 500, not more than 500. Another question by Dr. Hind, two situations of propylcyracil. As I mentioned previously, propylcyracil is only indicated in Graves' disease if during the first trimester or prepare for a pregnancy within the 6 months, or there is a previous history of pancreatitis or side effect of carbimazole. In this situation, we should start by propylcyracil. And another indication to start with the propylcyracil in a case of thyrotoxic crisis. In this situation, we should start by propylcyracil because this is a life-saving condition. And the propylcyracil is prevent the conversion of T4 to T3. So this in this situation have a more benefits than carbimazole.
Dr. Khalid, if the
Dr. Sana asked
patient
during the
receives,
first yes.
yeah, if the patient received radioactive iodine and the TSH normalized after 6 months, but the
Yes.
patient is symptomatic with the symptoms of hypothyroid, should we start thyroxine in this case?
No, once the TSH is normal, no need for levothyroxine. But actually, most of cases received radioactive iodine will go to hypothyroidism later on. So we should long-term follow up by TSH. Once the TSH is elevated, in this situation, I will start levothyroxine. Dr. Sana asked during the 6 months of follow-up and the T3 and the T4 normalized, but the TSH is still suppressed. Do we decrease the carbimazole dose? Actually, we decrease the dose of carbimazole if the T3 and the T4 lower half of the normal. In this situation, I will decrease the dosage of carbimazole. But if the T3 and the T4 upper half of the normal, in this situation, I will not reduce the dosage of carbimazole. So usually we follow a patient with a recent onset Graves' disease received antithyroid drug by TSH, free T4 and free T3. I will reduce the dosage of carbimazole if T3 and T4 normalized and in lower half of the normal or low normal. In this situation, I will decrease carbimazole. Till in normalization of the TSH, in this situation, I will follow the patient by TSH alone. For adult children and young adults with a TSH in the reference range 12 months after radioactive iodine, we should consider TSH measurement plus cascading every 6 months unless they develop hypothyroidism. If there is a manifestation of hypothyroidism in this situation, I will doing a TSH. With cascading means if it TSH is normal, no T3 or T4. If it TSH is low in this situation, I will doing free T4 and free T3. If it TSH is elevated in this situation, I will doing free T4. This is what I mean with cascading. How soon to test TSH after radioactive iodine therapy? Actually, in the every month until in normalization or according to the general condition. If the patient is still symptomatized, if the patient is still thyrotoxic, and I will cover it, this point. If hyperthyroidism persists after radioactive iodine treatment in adult and children, consider antithyroid drug until the 6 months appointment. If hyperthyroidism persists 6 months after radioactive iodine ablation, in this situation, I will consider further treatment by another dosage of radioactive iodine ablation or surgery if indicated. So, if usually the patient after receiving radioactive iodine is still thyrotoxic for 3 to 6 months. So after radioactive iodine ablation, I will restart the carbimazole after 3 months of radioactive iodine ablation, but by small dose, and decrease it according to the response, according to the thyroid function test, which is done routinely every 1 month till 6 months. If the patient is still on carbimazole after 6 months or is still thyrotoxic, in this situation, I will the patient will need another dosage of radioactive iodine, and actually about 15% of the patient need another dosage of radioactive iodine twice or 3 times. Actually, I have one patient need a radioactive iodine 3 times.
Dr. Khalid, not after 5 days we can start carbimazole?
Usually after 3 to 5 days or 3 to 7 days, actually, after radioactive iodine.
3 to 5 days, yes, okay. Thank you,
Dr. Muhammad asked, bottle carbimazole excreted in the milk. Yes, carbimazole is excreted in the milk. Propyl thyroxine also excreted in the milk, and also thyroxine excreted in the milk. But actually, during lactation, if the patient in a dosage less than 30 milligram, it is has no side effect for the fetus for carbimazole. So الكربمازول is allowed during lactation up to 30 milligram. البروبايل ثيراسيل السايد effects is fatal of it, specifically acute liver cell failure. So the indication of propyl thyroxine is limited to a very few indications only. No, Dr. Manar, if this drug is used in lactation, we monitor the infant thyroid function? No. Except if there is a manifestation of thyroid dysfunction in the infant. In this situation, I will check the thyroid status of the infant. But usual routine screening, no. For the infant, lactating infant. After how many months should we give a second dose of radioactive? Not less than 6 months. Not less than 6 months. If we need a second dosage of radioactive iodine, not less than 6 months. Yes, as mentioned by Dr. Najia. And this is, I mentioned, if hyperthyroidism persists 6 months, consider further treatment by another dosage of radioactive iodine. Can we separate between lactation and antithyroid drug, Dr. And actually, carbimazole have a long half-life. So if you separate it by some duration, it will be secreted in the milk. But actually, practical point, we can divide the dosage. The carbimazole has a half-life, and we can give it once daily. But if the patient, lactating female, need more than 1 tablet, we can divide it into 2 or 3 times per day. But actually, routinely, carbimazole can be given once daily. This is the same efficacy as twice per day. But during lactation, it is recommended to divide it into twice a daily dosage. How to monitor after surgery? Actually, after a total thyroidectomy, we should offer levothyroxine immediately in the next day after the total thyroidectomy. And how to follow up? We should measure TSH and the free T4 at second, 2 and 6 months after surgery to readjust the dose of levothyroxine. And then TSH with cascading once a year for adult for assessment of thyroid status. Dr. Mohammed, if ask it means if the patient need more than 30 milligram, we recommend to stop lactating. Actually, most of the patient, very rare situations, the patient require more than 30 milligram. But actually, up to 30 milligram is compatible with breast lactation. If the patient require more than this dosage, I will recommend weaning off breast feeding. How to monitor is the anti-thyroid drug? As I mentioned, TSH, free T4 and free T3 every 6 weeks until their TSH is within the reference range. Then TSH with cascading every 3 months. Don't monitor full blood count, liver function test for adult, children, and young people taking anti-thyroid drug unless there is a clinical suspicion of a granulocytosis or liver function, because a granulocytosis occurs abruptly. So screening for a granulocytosis is not have a benefit. Once a granulocytosis occurs, you should stop or suspect a granulocytosis, we should stop the drug and doing CBC. But routine CBC is not recommended.
My carpet praying also. That's all.
So we should reassess CBC and liver function test before starting anti-thyroid medication, and doing it if we suspect a granulocytosis or liver affection. How to manage and monitor subclinical hyperthyroidism? Subclinical hyperthyroidism means TSH is low with normally free T4 and T3. Both T3 and T4 must be normal. Consider seeking specialized advice on managing subclinical hyperthyroidism if TSH 2 TSH reading lower than 0.1, at least 3 months, and evidence of thyroid disease. In this situation, to treat or not to treat need a specialized advice. And actually, I will cover the management of subclinical hyperthyroidism with the European Thyroid Association guidelines published in 2015 for managing of subclinical hyperthyroidism. And this is very important guidelines. We should consider measuring TSH every 6 months if the patient with subclinical hyperthyroidism not treated. We should consider TSH, free T4, free T3 every 3 months for children and young people with untreated subclinical hyperthyroidism. Diagnosing and managing and monitoring thyroid enlargement with normal thyroid function. This is a case mostly of thyroid nodule or diffuse thyroid pathology with normal thyroid function. In this situation, in ultrasonography, we should do thyroid sonography to image palpable thyroid enlargement. And in this situation, we should being thyroid sonography, and we should comment about a lot of features like echogenicity, microcalcification, borderless shape, internal vascularity, and the lymphadenopathy. And in this situation, the main role of thyroid ultrasonography to guide the need for performing fine needle aspiration cytology. Actually, the main role of thyroid sonography in assessment of thyroid nodule is to choose which nodule to be biopsied. And of course, fine needle aspiration cytology is the gold standard for management of thyroid nodule. Managing a non-malignant thyroid nodule, don't offer treatment to adults with non-malignant thyroid enlargement with normal thyroid function test and mild or no symptoms unless. So the indication for a treatment of non-malignant thyroid nodule, breathing difficulty in this situation, it requires surgery. A clinical concern, for example, marked airway narrowing, and also this is an indication for surgery. We should repeat thyroid sonography only if malignancy is suspected or compression is suspected, or a person's symptoms worsen or develop a new symptom like hoarseness or shortness of breath. In this situation, I will repeat thyroid function test with the TSH. Of course, if thyroid nodule is a cyst or a predominantly cystic nodule, in this situation we can aspirate with possible ethanol injection, ethanol ablation. This is a very important. So ethanol ablation is only indicated if the cyst is the nodule is cyst or a predominantly cystic nodule alone with no vascular component. In this situation, ethanol ablation is indicated. Adult with normal thyroid function and non-cystic nodule or multinodular or diffuse goiter, consider the following if they have compressive symptom. Surgery is the first choice if there is a marked airway narrowing. Radioactive iodine is indicated if there is a demonstrable radionucleotide uptake. And another indication, another treatment modality is percutaneous thermal ablation. So percutaneous thermal ablation is indicated in non-cystic nodule. But in this situation, we should exclude the malignancy by doing two fine needle aspiration cytology, and both two aspiration denote a benign cytology. In this situation, percutaneous thermal ablation is indicated, and actually I cover this in a ThyroAlex presentation about non-surgical management of benign thyroid nodule. And actually, the European Thyroid Association gave a very important guidelines about this tool. Which specialty deals with ablation? Actually, some of radiologists deal with it. Also, some of endocrinologists can manage and doing percutaneous thermal ablation or ethanol ablation. So both radiologists can doing it, and another one experienced endocrinologist. No, actually, nuclear medicine is not doing percutaneous thermal ablation, Dr. Suhail. And nuclear medicine mainly for radioactive iodine ablation, not percutaneous thermal ablation or ethanol ablation. Ethanol ablation and percutaneous thermal ablation need to be done under ultrasonographic guide, and this is only done by experienced endocrinologist or interventional radiologist. Dr. Muhammad asked, can you explain the role of radio frequency ablation of benign? This is a very big topic, Dr. Muhammad, and you can go to my presentation in the ThyroAlex about this management, because I cover it in more details. So I can, if you use some of this presentation, actually, this is one, and you. This is a benign thyroid nodule in ThyroAlex, benign thyroid nodule. This is one. So I will cover it in ThyroAlex 11, and this is how to doing thermal ablation and التفاصيل and with full details. And actually, this is a Korean guidelines for management of ethanol ablation and how doing ethanol ablation. This is one, and another one is thermal ablation, and this is the guidelines published by the ETA about the image guided ablation in the benign thyroid nodule, and I cover a different modality laser radio frequency ablation, and this is full details of this procedure, and I can upload it later on. Dr. Sana asked thyroid nodule with low TSH and positive TSH receptor go to the fine needle or scan. Actually, we should go to the fine needle aspiration cytology. In this situation, as the TSH receptor antibody is positive, so low TSH due to the underlying Graves' disease. So this is a nodule in a patient presented with a Graves' disease. So what is the next? Doing fine needle aspiration cytology, not radioactive iodine scan. And actually, this is the last slide in a nice guidelines, and this summarize how to manage a patient with hyperthyroidism in adults, how to manage and how to monitor. A nice recommend nowadays consider an antithyroid drug with supportive treatment while awaiting specialized assessment. Offer antithyroid drug in specialized care to people waiting for radioactive iodine or surgery. And we have three types of modalities for treatment: radioactive iodine, antithyroid drug, and surgery or thyroidectomy. Radioactive iodine is offered as a first-line definitive treatment for a Graves patient with a Graves disease or and toxic multiple nodule, or a patient with a single toxic adenoma, as an alternative to surgery except pregnancy, fathering a child within 6 months, thyroid eye disease, compression, or suspect of malignancy, because the pregnancy need medication. Fathering child within 6 months, in this situation, I will go to the surgery, compression surgery, thyroid eye disease surgery or radioactive or antithyroid drug, suspect of malignancy surgery in this situation. How to follow up? By measuring TSH and FT4 and FT3 every 6 months for the first 6 months until TSH normalization. If the patient is thyroid, in this situation, I will check TSH at 9 and 11 months, and then every 6 months if TSH is normal at 12 months. If the patient is hypothyroid, I will give thyroxine. If not taking antithyroid drug, if the patient is still thyrotoxic, I will consider antithyroid drug until 6 months. After that, I will give a second dosage of radioactive iodine. Another modality, antithyroid drug is offered for Graves' disease for 1 to 1.5 years, if likely to achieve remission or if other treatment is suitable. And I will give in toxic adenoma or toxic multinodular goiter lifelong treatment. And in this situation, I will consider radioactive iodine or surgery for Graves' disease with persistent or relapsed hyperthyroidism. Consider measuring TSH, FT4 and FT3 every 6 months until normalization of the TSH, then TSH every 3 months. After stopping antithyroid drug, I will consider measuring TSH within 8 weeks, then every 3 months for a year, then once a year. So this is very important, how to follow a patient with antithyroid drug. After stopping antithyroid drug, after 12 to 18 months course for adult, we should consider measuring TSH within 8 weeks, then every 3 months for a year, then once a year. If TSH is decreased with elevation of thyroid hormone, this is a case of relapse of Graves' disease. In this situation, the most accurate definitive treatment is radioactive iodine or surgery. And also a long-term low-dose carbimazole can be suitable for some cases. The last option for treatment of Graves' disease is surgery or by total thyroidectomy. The Graves treated by total thyroidectomy, of course, if there is a compression or suspicious of malignancy or if other treatment unsuitable. A toxic adenoma, single adenoma can be treated by hemithyroidectomy. By toxic multinodular goiter should be treated by total thyroidectomy. And after surgery, we should give levothyroxine after total thyroidectomy. What is the dosage of levothyroxine? Like a dosage for overt hypothyroidism, 1.6 microgram per kilogram per day. And of course, the same precaution if the patient is elderly or cardiac, we should start by a low dose and increase the dosage after 2 to 3 weeks. Consider measuring TSH and FT4 at 2 and 6 months after hemithyroidectomy, then yearly. and of course, as recommended by the guidelines with cascading, which mean measuring free T4 in the same sample if TSH above a reference range, or free T4 and free T3 in the same sample if TSH below the reference range to save your patients money. And actually, this is the last slide in the NICE guidelines published in 2019. And if anyone want any question about this, one of the most important guidelines for the exam.
So, Khalid, it is very difficult to remember the time of follow-up.
Your voice, Dr. Mahawish, is very low. Yes, Dr. Saadeh mentioned that radioactive iodine as a first line in practice, everyone goes to anti-thyroid drug, and actually all world except American choose anti-thyroid drug as a first choice. But the last guidelines and the last edition of the Oxford Handbook of Endocrinology and Diabetes, they increase the usage of radioactive iodine as a first choice, except in the situation in which radioactive anti-thyroid drug will the patient remit after receiving it. Why they doing this? Because the relapse after a thyroid anti-thyroid drug is about 60%.
السلام عليكم دكتور خالد.
Dr. Mahawish mentioned that there is a difficult to remember timing of follow-up and the timing of thyroid function test. Actually, with repeating this and with clinical practice of this, you will follow it and you will memorize it actually. The last edition of the Oxford, I mean fourth edition. Oxford Handbook of Endocrinology and Diabetes, fourth edition. If you see it, not a big difference actually between the third and fourth edition, but there is a lot of the updates, not a lot, but actually if you need updated data, you need to go to fourth edition. For example, radioactive iodine has a priority nowadays than the anti-thyroid drug. But in our clinical practice, this is a different from country to the country to another country. In most of our countries, the anti-thyroid drug is still the first choice, even if the relapse is whole.
السلام عليكم دكتور خالد.
وعليكم السلام ورحمة الله وبركاته.
كنت عايز اسال بخصوص الانتي تي بي او. To what extent the anti TBO is indicated in patients with TSH less than 10 and normal FT4 for all cases?
Yes, actually, if the anti-TBO is positive, I will treat. If the anti-TBO is negative, I will not treat. So, subclinical hypothyroidism with the TSH is less than 10. This is one of indication for doing thyroid autoantibody. This is a very important because it will decide who to treat and who not to treat.
Yes. طب معلش في سؤال تاني. Target TSH in patient with hypothyroidism associated with Addison disease, the upper or lower limit of reference?
Usually the indication is normalization of the TSH. This is recommended. But usually, yes. And this is asked by Dr. Najah, what is the target of the TSH during treatment of hypothyroidism? Most experts recommend TSH lower half of the normal, less than 2.5, like pregnancy actually. This is must be for the fertility and the pregnancy. But another situation like your patient, Dr. Nader, with Addison, we can bring it just a normalization of the TSH. But if TSH in the upper half of the normal and the patient is still symptomatized, in this situation, it is recommended to increase the dose of levothyroxine to bring TSH to be less than 2.5.
العيان ساعتها بيبقى على ستيرويد ثيرابي علشان الاديسون ده بيمسك طبعا. صح كده؟
Yes, actually a dosage of corticosteroid that affected TSH is the large dosage of corticosteroid. A dosage of corticosteroid for replacement therapy in Addison, this is a physiological dose of corticosteroid and will not affect a TSH magnitude.
الجلوكوكورتيكويد هو اللي بيأثر اكتر من الفلودريكورتيزون بقى ولا
Yes,
علشان
yes,
عيان
mainly glucocorticoid which affected TSH, but this is for large dose of glucocorticoid, not physiological replacement therapy for Addison's disease.
الفلودريكورتيزون ملوش افكت هنا يا دكتور خالد؟
I think no.
طيب معلش سؤال اخير بقى why we need to monitor CBC before starting carbimazole
Because at least to know that there is a mild leukopenia, because the anti-thyroid drug may affect the leukocytic count, decrease the leukocytic count. So in this situation, if the leukocytic count is borderline, and in this situation I will start by small dose and follow up. We can affect management protocol.
يعني as a baseline for future comparison.
As a baseline. Also, anti-thyroid drug affect liver function, so you need to know your baseline.
Yes, شكرا.
And Dr. Najah asked about the targets of the TSH, the same in adult and elderly. Actually, for the adults, normalization of the TSH or to be less than 2.5, and for the elderly, most of the recommendation, TSH is less than 8. Not normalization not to be less than this number.
Dr. Khalid, is there any
actually,
guideline?
Dr. Ashraf, this Dr. Agassi just Dr. Ashraf asked, do we start levothyroxine at a dosage of 1.6 to all patients with overt hypothyroidism regardless the etiology? Yes, this is a recommendation actually, but actually this is for young adult. For elderly, we start by small dose, and this can be different. For example, if TSH is, for example, is 12 and overt hypothyroidism, actually I will not start by this large dose. There are two protocols actually in the guidelines to titrated dose or to start by full replacement dose, and both regimens are the same efficacy, and most experts recommend to full start by a full replacement dose. But actually, according to the TSH magnitude and manifestation symptoms for your patient, in this situation maybe affect your decision to start by full replacement dose or to decrease it, and after following up by doing a TSH, I will increase the dosage. Yes, Dr. Casey?
Yes, Doctor. Dr. Khalid, is there any clear guideline regarding a patient going for surgery, pre-operative management of patient going for surgery with the thyroid disease?
Actually, no. Actually, for thyrotoxicose, you will find it with the guidelines published by American Thyroid Association. There is a section for perioperative management, and for hypothyroidism, I don't remember any guidelines mention this topic. Just a chapter in textbook, not a guideline, not specific guidelines for this issue, Dr. Casey.
Okay, thank you.
Dr. Chavan asked, when it TSH upper limit of the normal, what is the dosage of restarting levothyroxine? Is it 1.6 or low dosage? Actually, this is a case of subclinical. In this situation, we start by a small dose, and I will cover it in the following guideline, because there is a guidelines about subclinical hypothyroidism, and in this guidelines, I will cover how to start by levothyroxine. And this is the second most important. Yes.
Dr. Khalid, I ask about radioiodine therapy for according to stop conception, men or women, because the last exam two question about this idea, 4 or 6 months.
Actually, and I repeated several times, and actually I will cover it in this guidelines, the British Thyroid Association guidelines, because in the British Thyroid Association guidelines they mention that for men 4 months, for women 6 months. But actually in the European Thyroid Association guidelines for Graves' disease, they recommend to stop for both male and female for 6 months. And I will put these guidelines actually in this to see it. This is Mary Graves. This is one. this is the guidelines published by European Thyroid Association for management of Graves hyperthyroidism, and they mention that I will go to the recommendation. This is one. Conception should be postponed until at least 6 months after radioactive iodine in both male and female. And this is the European guidelines. 6 months after radioactive iodine in both male and female. But if we see these guidelines, a few slides later, I will cover it. 4 months for male, I will show it. This, I think, isolation and disadvantage. This is one. They mention this is a British guideline 2014. Need to avoid the pregnancy 6 months or fathering a child 4 months. So a British recommendation recommend avoid fathering for male 4 months and for female 6 months. But the updated British Thyroid European Thyroid Association recommends 6 months for both male and female. So I think to answer this question in a sub-specialty examination, I will choose 4 months for male, and for European board examination, I will choose 6 months for male. So
Okay,
this is
thank you, Dr. Khalid.
okay. Yes, also Dr. Najah in the Oxford the last edition, they mentioned the same. So I will go to the British Thyroid Association guidelines, and this is a very important guidelines and a very few slides because this is a very large guideline. And if anyone want to understand how to manage thyroid cancer and how to follow up, please read this comprehensive guideline. And this is actually published in 2014 and no updated version from it up till now. First of all, they mention that patient with thyroid nodule who may be managed in primary care, any patient present with thyroid nodule not changed over several years. For example, if we have in our clinic a patient presented with thyroid nodule since 20 years ago, without alarming manifestation, without changing in the size, please no need for doing fine needle aspiration cytology in this situation because this is a stationary course, no change it for several years, and who have no other worrying feature. But if the patient is symptomatized, increased size, for example, or there is alarming manifestation in thyroid sonography, in this situation, I will doing fine needle aspiration cytology. Another one indicate to be managed in primary care if asymptomatic nodule less than 1 centimeter. In this situation, we can manage in primary care. Another one, when to refer non-urgent referral if there is a sudden onset of pain in the thyroid lump. This is an indication of hemorrhage in the cyst, in thyroid nodule, and this is indication for referral, but non-urgent referral. And actually, in the Oxford, they in the Atoll book give this very important table. And this actually from the guideline when to manage in primary care if the nodule unchanged in the size, if non-palpable asymptomatic thyroid nodule less than 1 centimeter, non-urgent referral if abnormal thyroid function test or sudden onset of the pain in the thyroid lump or gradually enlarging over months. But we should refer within 2 weeks urgent referral if there is unexplained hoarseness of voice, if there is cervical lymph node, suspicious cervical lymph node, if there is thyroid nodule in children because the risk of malignancy is high, if rapid enlarging over week, painless thyroid mass. But we should refer urgently in the same day if there is a presence of stridor. So a presence of stridor require referral at the same day, and this is very important. Another one, because this is different than the American guidelines, in British Thyroid Association guidelines, they not choose a size of the nodule as a landmarker for doing fine needle aspiration biopsy. Why? Because the evidence does not support a size as a reliable indicator of malignancy. So in British guidelines, they don't recommend fine needle aspiration cytology according to the size, But American recommendation, American guidelines, and the thyroid classification choose the fine needle aspiration cytology according to the risk pattern and size of the nodule. And this is very important. The ultrasonographic feature indicative of benign and malignant or suspicious of malignant nodule. The ultrasonographic feature indicative of the benign spongiform or honeycomb appearance, pure cystic nodule, eggshell type calcification around the periphery of the nodule, and peripheral vascularity. This is a benign feature of the thyroid nodule. What is the feature indicative of malignant nodule? For papillary and medullary thyroid cancer, solid hypoechoic with microcalcification, irregular margin or intranodular vascularity, taller than wider, irregular speculated margin, eggshell type calcification with a broken calcified rim or with extension beyond calcified rim. And for follicular region, hyperechoic homogeneous, hypoechogenicity and loss of associated halo, this is a follicular lesion. And actually, U classification is very important, U1, U2, U3, U4, and U5. And actually, this table summarizes each one. Don't forget that U1 is a normal thyroid gland, no thyroid nodule. U2, this is a benign thyroid nodule, which means isoechoic or hyperechoic nodule, mildly hyperechoic nodule, peripheral vascularity, peripheral eggshell calcification like this and this. And indeterminate or equivocal, like which is U3. U4 is suspicious of malignancy, hyperechoic or solid, very hypoechoic nodule, disturbed peripheral calcification or lobulated outline like this image. U5, this is a malignant thyroid nodule in which there is a microcalcification like this, or solid hypoechoic lobulated irregular outline. And this is a unique for medullary thyroid carcinoma. This is one. This is mostly medullary thyroid carcinoma, or intranodular vascularity like this, or taller than wider, which is a malignant feature, or there is associated suspicious lymph node. This is a criteria for thyroid malignancy. And actually, how to follow up a thyroid nodule, this is a very important in the clinical practice and exam. And actually, they recommend nodule with a benign, which is after doing fine needle aspiration cytology. If it is Cy2, this is a benign cytology results. And benign ultrasonographic criteria, in this situation, we don't need to repeating fine needle aspiration cytology. But if the nodule is Cy2 cytology, but by sonography, there is indeterminate U3 or suspicious ultrasonographic feature U4, in this situation, I will repeat fine needle aspiration cytology for confirmation. And actually, this is a very important table, Cy1, Cy2, Cy3A, and Cy3F, and Cy4 and Cy5 for the exam. What is the next option for this Cy? And actually, this table summarizes all Cy and description of the Cy and what is the action needed after this Cy classification. And this is very important in clinical practice and in exam. For example, Cy1, this is a non-diagnostic, and of course, non-diagnostic cytology means reassessment and repeating fine needle aspiration cytology. Cy2, this is a non-neoplastic. This is a non-neoplastic, not a benign. Cy2, non-neoplastic. In this situation, correlate with the clinical and ultrasonographic finding. In some situation, I will do nothing, no follow-up, but in another situation, I will repeat fine needle aspiration cytology if the patient have a high risk of malignancy, for example, previous radioactive iodine ablation, family history of thyroid cancer, or U3 or U4. What about the Cy3, which is Cy3A atypical? In this situation, I will repeat fine needle aspiration cytology. Cy3F, this is a follicular neoplasia. I will do hemothyroidectomy because the risk of malignancy is about 10 to 40% risk of malignancy. And actually, this is a very repeated question in the all of a previous exam. They usually ask about the risk of malignancy in Cy3F. And what is the action with Cy3F? Cy4, this is a suspicious of malignancy. I will do hemothyroidectomy diagnostic. Cy5, this is a diagnosis of malignancy, medullary thyroid carcinoma or differentiated follicular or papillary. How to treat? Surgery is the first option. Radiotherapy or chemotherapy for anaplastic or lymphoma. And this table and this algorithm is very important, how to investigate and how to follow a patient presented with a thyroid nodule. The first one, I will doing thyroid sonography. Thyroid sonography, this is a very important step in assessment risk pattern of the thyroid nodule. If it is benign U1 and U2, the next step is no follow-up in this situation. But if U3 and U5, in this situation, I will go to fine needle aspiration cytology. Fine needle aspiration cytology, Psi1, Psi2, Psi3, Psi4, Psi5. Psi1, this is a non-diagnostic, and I will repeat fine needle aspiration cytology. Psi2, in this situation, this is a non-nebulastic review and the clinical and ultrasonographic level of suspicious. If low level, so no follow-up. If high level, I will repeat fine needle aspiration cytology. If Psi3, in this situation, I will consider neoplasm possible. Psi4 suspicious, in this situation, consider repeat fine needle aspiration cytology or core biopsy. And if there is a suspicious, I will go to diagnostic or therapeutic surgery. If Psi5, in this situation, I will go to the therapeutic surgery for thyroid cancer. And this algorithm is very important. And another very important topic covered in the guidelines, radioiodine remnant ablation and therapy for differentiated thyroid cancer. What is the advantage of radioiodine remnant ablation? Of course, possible prolonged survival, eradication of all residual thyroid tissue, so a recurrence will be decreased, reduce the risk of local and distant recurrence. Also will increase the sensitivity of TG monitoring, because the follow-up of differentiated thyroid cancer usually by doing TG, so sensitivity of TG will be increased after radioiodine remnant ablation. Also will increase the sensitivity of subsequent iodine scanning. If required, the whole body scan will be increased in sensitivity of it. What is the disadvantage of radioiodine remnant ablation? Of course, need to avoid the pregnancy for 6 months or fathering a child for 4 months. A slight increase in risk of miscarriage, hospital stay in isolation, need to maintain a safe distance for a period, painful thyroiditis, radiation cystitis or gastritis or bleeding or edema from metastasis, and this is a very rare side effect, nausea, and of course sialadenitis, xerostomia, in which this is a dry tongue, xerostomia. This is a side effect usually occur after radioiodine remnant ablation. Dysgeusia, in which the patient suffer from abnormal tasting in the mouth. Also a rare side effect, which is pulmonary fibrosis, and another one is second malignancy risk may be higher than previously thought. Second malignancy may be increased in some studies. And this is a very important table in whom we need to do radioiodine remnant ablation for differentiated thyroid cancer. The patient need radioactive iodine ablation. The first one, no indication. When radioiodine remnant ablation is not recommended, all the criteria below should be met. If the tumor size is less than 1 centimeter, if histology classical papillary or follicular variant of papillary carcinoma or follicular carcinoma, minimally invasive without angio invasion, no invasion of thyroid capsule. If any patient presented by these 4 criteria, in this situation, no need for radioiodine remnant ablation. Tumor less than 1 centimeter, histology classical papillary or follicular variant of papillary thyroid carcinoma, minimally invasive without angio invasion, no invasion of thyroid capsule extrathyroidal extension. In this situation, no need for radioiodine remnant ablation. But if the patient presented with a tumor more than 4 centimeters, the tumor with a gross extrathyroidal extension, distant metastasis present, in this situation, we should doing radioiodine remnant ablation. So this is a very important. No indication for radioiodine remnant ablation, definitive indication for radioiodine remnant ablation. But another category is there is uncertainty about indication to give radioiodine remnant ablation or not. This is maybe different according to the localized protocol. If there is a large tumor size, extrathyroidal extension, unfavorable cell type, widely invasive histology, multiple lymph node involvement, in this situation, the patient may have a beneficial from radioiodine remnant ablation. But if this criteria is not presented, we can go without radioiodine remnant ablation. And this is a very important table to decide whom need to doing radioactive iodine ablation after differentiated thyroid carcinoma and whom not require this regimen. And actually, how to prepare your patient to for doing radioiodine remnant ablation? We have three options actually. The first one, if the patient already doing total or near total thyroidectomy more than 4 weeks. In this situation, you need to know that before doing radioiodine remnant ablation, TSH must be more than 30. Must be more than 30. And actually, after total thyroidectomy, for any reason, we will give levothyroxine, which decreases TSH. So, the first option for preparing for radioiodine remnant ablation, if the patient doing surgery more than 4 weeks, in this situation, I will stop levothyroxine 4 weeks before radioiodine remnant ablation and give liocyanine because liocyanine has a short half-life. So we can stop liocyanine 2 weeks before radioiodine remnant ablation. In this period, 2 weeks after stopping liocyanine and actually 4 weeks before stopping levothyroxine, TSH will be increased more than 30 because liocyanine have a short half-life than levothyroxine. And actually, we should put our patient in low iodine diet for 1 to 2 weeks before radioactive iodine ablation, and then we will give radioactive iodine ablation. Another option, if the patient already doing the surgery less than 4 weeks before remnant ablation. In this situation, we will start by liocyanine, which is T3, which is a short half-life, and we should stop by 2 weeks before remnant ablation, and then we will put our patient on a low-dose radioiodine diet for 1 to 2 weeks. Another situation, in some situations, we cannot stop levothyroxine. In this situation, and this is the most expensive regimen and the most accurate regimen actually, by giving the patient already levothyroxine and the patient already levothyroxine and we will give Thyrogen, which is recombinant human TSH, which lead to elevation of the TSH more than 30, and it will be given as a twice injection. One of them is 48 or 2 days before the remnant ablation, and another dosage 1 day before remnant ablation. And actually, as I mentioned in the previous session, this is not correct in the guidelines. This arrow is not correct. This must be removed from the guidelines because here he mentions that 2 weeks before we should stop levothyroxine, but actually we will not stop levothyroxine until the dosage of radioactive remnant ablation. And actually, all patients should be put in low iodine diet 1 to 2 weeks before radioiodine remnant ablation. So this is a very important how to prepare your patient for remnant ablation or radioactive iodine ablation therapy. Possible early adverse effect following radioactive iodine ablation, and this actually is covered previously. Dysgeusia and cyanidinitis. Dysgeusia, which is abnormal taste in the mouth, nausea, neck discomfort, and swelling within a few days, and this will relieved by non-steroidal anti-inflammatory drug, and radiation cystitis or radiation gastritis and bleeding, and this is actually treated by a high intravenous fluid and oral fluid to improve it. Yes?
Yeah, Dr. Khalid.
Yes, doctor.
The follicular variant of biliary thyroid cancer, because the WHO now they classified it
This
as
is
a
actually
phenotype.
resistant to radioactivity ablation. Actually, this is one of cancers that resistant to radioactivity ablation.
So no need to give you. That's me.
Yes.
Okay. Thank you, sir.
And this is the possible late adverse events following radioactive iodine ablation: xerostomia, dysgeusia, chylomicrosis, lacrimal gland dysfunction. And don't forget that the lifelong incidence of leukemia and second cancers is low. It is about 0.5% of the patient. And actually, this is a debatable point across the studies. So most of authorities not recommend radioactive iodine ablation for children less than 5 years because this concern of increasing risk of leukemia and second cancer. And actually, this is an assessment of radioactive remnant ablation. And actually, in the previous session, I will put this figure from this important paper and not from the guidelines. So this figure is not belong to the British Thyroid Association guideline. How to assess radioiodine remnant ablation, and it is important to doing stimulated how can calculate the dosage of radioactive iodine ablation, or it is a role of nuclear medicine? Usually it is endocrinological decision. And but in most of our localities, a nuclear medicine physician choose the dosage according to the risk stratification of the patient, usually a fixed dose. But if there is metastasis or recurrence, the dosage of radioactive iodine will be more than if this is the first time. So how to assess remnant radioactive iodine ablation success? By doing stimulated TG and neck ultrasonography, and this is a preference to a diagnostic whole body scan between 9 and 12 months. Recombinant human TSH is the method of choice for TG stimulation, and this is when doing TG stimulation, and this is usually done, TG assessment done after 5 days from the first Thyrogen injection, 5 days or 96 hours. And if thyroxine withdrawal, serum TSH concentration must be more than 30 to be effective for giving remnant ablation. And the next sonography should be used for assessment of recurrence and the residual tissue. And of course, Thyrogen, which is recombinant human TSH, is the only possible or safe option for diagnostic purpose in a case of hypopituitarism. If the patient presented with hypopituitarism, in this situation and differential thyroid cancer, we should give Thyrogen. If the patient presented by severe ischemic heart disease and we cannot stop levothyroxine, in this situation, Thyrogen is the only possible drug to be used for remnant ablation, before giving remnant ablation. Also, if the patient presented with a previous history of psychiatric disturbance, in this situation, stopping levothyroxine can precipitate severe hypothyroidism. In this situation, Thyrogen is mandatory. Advanced disease and frailty, in this situation, we need to give remnant ablation immediately. In this situation, we should give Thyrogen and doing whole body scan after a few days. And actually, the last slide in this guideline, so if anyone has a question, it is welcome. Yes, Dr. Ashar.
Just I wanted to ask, what is the association between having high TSH and the success rate of the radioactive iodine remnant ablation?
to be sure that الثيرويد remnants of thyroid follicles can absorb radioactive iodine. If TSH is low, this will decrease the avidity of thyroid follicles to attract radioactive iodine. So we must be sure that TSH is more than 30 to be effective.
Okay, Jazakallah.
So this is the last slide in this guideline, and I will go to another very important guideline. If anyone has a question about thyroid cancer, there is a rule for assessment of thyroglobulin. Yes, Dr. Mohammed, and actually we will cover this in more details in the previous session about thyroid cancer in the previous Friday. We will cover thyroid cancer and how to follow up of differentiate patient with differentiated thyroid cancer, and when doing thyroglobulin, and what is the role of anti-thyroglobulin, because each time you do follow up by thyroglobulin, you should doing anti-TG, because if anti-TG is positive, this will affect the assay of thyroglobulin. If thyroglobulin is low, this may be falsely low. So you can go to the previous session about thyroid cancer and full details for the follow-up of patient with differentiated thyroid cancer, or go to the guidelines published by British Thyroid Cancer, because there is a very large chapter about the follow-up of a patient with differentiated thyroid cancer. And actually, I will start by chronologically by these guidelines. This is published in 2012. European Thyroid Association guidelines for the combination therapy, levothyroxine plus liocyanine in the treatment of hypothyroidism. And actually, this is a very important aspect. When we need a combination therapy with levothyroxine plus liocyanine, if the patient is still symptomatized in irrespective even after normalization of the TSH. But actually 5 to 10% of our patients after normalization of the TSH will have a persistent symptom of hypothyroidism. Why is this occur? Because this is a possible cause of persistent complaint after normalization of the TSH in the hypothyroid patient, non-specific cause related to the chronic nature of the disease, and also another specific cause like associated autoimmune disease, thyroid autoimmunity per se, or inadequate of levothyroxine dose, or inadequate levothyroxine treatment modality. For example, the patient is still normalized the TSH, but what about a tissue T4? What about a tissue T3? Is it normalized or not? This is may be responsible for persistent complaints of hypothyroidism. But so this is the sum of possible cause of persistence complaints after normalization of the TSH that may indicate to search for another treatment for hypothyroidism. So before starting of combination therapy, we should explain the persistent symptom to our patient and mention that your patient is aware of its chronic disease. We should search for another autoimmune disease. We should suspect that thyroid autoimmunity anti-TPO per se may be cause of these symptoms, persistent symptom, or there is inadequacy of levothyroxine that restore physiological T4 and T3 concentration in the serum and tissues. This is a very important, and we have no laboratory method to investigate the normalization of the tissue T3, which is active hormone. But we should know that levothyroxine as a monotherapy remains the standard treatment of hypothyroidism up till now. This is the only indicated treatment of hypothyroidism. But combination therapy is considered experimental approach to the patient already in levothyroxine, but still persistent complaints despite normalization of the TSH. In this situation, we can add liocyanine T3, but with specific precautions and adjustment. We should know that a combination therapy is not recommended in pregnant female. Is not recommended in a patient with cardiac arrhythmia. And if the patient is not improved after 3 months, we should stop this combination and go to levothyroxine alone. So, the combination with levothyroxine plus liocyanine should be stopped if no improvement after 3 months of trial. And this is actually is very important. A ratio of T4 to T3, the dose ratio should be between 13 to 1 to 20 to 1 by weight. The dosage of levothyroxine should be 13 to 1 or 20 to 1 levothyroxine to liocyanine dose ratio. And another one, where levothyroxine can be given once a daily, the daily liocyanine dose should be divided. As we know that levothyroxine is a long half-life, liocyanine short half-life, so we should give liocyanine in a 2 divided doses if possible. In 2 doses, 1 before the breakfast and a largest dose 1 before the sleeping. So 2 doses, 1 before the breakfast and largest dose before the sleeping. This is very important. And this is a very important. Levothyroxine plus liocyanine is presented worldwide as a fixed dosage combination, and a ratio of T4 and T3 is different according to the company. For example, ProThyroid 100 microgram, 10 microgram, this is a ratio of T4 to T3 10 to 1. This is by Sanofi. Another one, Novocyril 100, this is a ratio 120, which is 1 to 5. Another one by Merck, Novocyril 75, this is a 75 microgram levothyroxine, 15 microgram liocyanine, which is a percentage of 5 to 1. And of course, this combination is not available in most of our countries. Actually, in Egypt, know this combination. Even T3 is not available in Egypt, and also in most of Arabian countries, liocyanine is not available, and fixed dose combination also is not available. But if it is available, according to the guidelines, it is recommended to use a separate levothyroxine separate than a liocyanine tablet, because a fixed dose combination we need to doing this dose ratio 13 to 1 to 90 to 1 to 20 to 1. But a fixed dose concentration, for example, this drug 5 to 1, which is not physiological dose. It is recommended that a combination therapy should be monitored by thyroid function test, blood sample withdrawn before morning medication have been taken, aiming at normalization of the TSH, free T4, free T3, and the free T4 free T3 ratio. This is a very important. And we know if these parameters is not normalized, we should adjust one of 2 components, liocyanine or levothyroxine, not 2 components. And usually we change liocyanine dose. So it is preferable to change the dosage of liocyanine, not levothyroxine. And this is very important to check thyroid function test after 6 to 8 weeks. It changes the dose of just 1 component. If serum free T3 is too low, in this situation, I will increase liocyanine. This is a very sufficient. And also, this is from the guidelines. If free T4 is too high, and actually, I think if free T4 is high, in this situation, the logical aspect, I will decrease the free T4 levothyroxine. But in the guidelines, they will mention that to increase the liocyanine dose will lower serum free T4. I don't know how, but this is what they said in the guideline. If free T3 is low, I will increase T3. If free T4 is elevated, we will decrease, we will increase the liocyanine, which will lower serum free T4. Therefore, in many instances, adjustment of liocyanine dose will be indicated, and this should be done by accredited specialist. And actually, this is the last slide in this guideline. And this combination therapy actually is not available in most of countries, so clinical practice of it is not present.
سؤال دكتور خالد بعد اذنك regarding this levothyroxine and L3 combination. What is the clear indication for use of T3 combination?
This is only indicated if the patient is still symptomatized after normalization of the TSH on levothyroxine.
Without
So in
testing
this
for
situation, we can give this as a trial of combination therapy to show if the symptoms is improved, so it is okay. If not improved, I will stop this combination. Why we start this? Because active hormone is T3, and we usually give T4, not T3.
even if there is the free T3 is normal while treatment with
Yes,
with T4
even if
only.
the T3 is normal, because the standardization of the T3 assay is not standardized actually up till now. So even after normalization of the T3, because actually symptoms may be due to the neurological T3 level, not the peripheral tissue. So this is a debatable point actually, but you should be sure that these symptoms is symptoms of hypothyroidism in a highly educated patient. Not anyone is not improved, so I will do this combination, and after reassessment of another causes of this symptom, because most of symptoms of hypothyroidism are non-specific. Asthenia, fatigue, hair loss, dry skin, and so on. These symptoms are not specific for hypothyroidism.
So I am sorry for interrupting Dr. Khalid, but so for the clear indication only if the patient is not improving symptomatically, even
Yes.
if T4 are normal, without
Yes.
testing for D2 deficiency.
Yes, because assessment of thyroid hormone level, tissue thyroid hormone level is not available.
Okay, thank you, Dr. Khalid.
Yes, I will do a break after this time at صلاة المغرب إن شاء الله دكتور مهاويش to save Zoom time. So what should be the timing of checking T3 giving its short half-life? As mentioned, and I mentioned this, Dr. Saadiyya, before receiving the drug. This should be monitored by thyroid function test in blood sample withdrawn before morning medication. Because actually, free T4, if we do reassess free T4 after levothyroxine, for example, it will be falsely elevated for at least 4 times, 4 hours. So, a timing of sampling must be assessed before withdraw or morning tablets. Yes.
If the patient is pregnant and she is on combination therapy, as we got one question in the previous exam.
Please, again, please.
If the patient is pregnant and she was on combination therapy.
Yes, and this is a question of the exam actually.
Yeah. Should we stop the T3 and increase the dose of T4, or we should just continue if she's euthyroid?
I am with stopping T3 and increase the dose of levothyroxine. And actually, I will cover it in the previous presentation, I think, not the previous thyroid with cancer, the previous one. We discuss thyroid disorders with pregnancy, and actually liocyanine is not recommended during pregnancy. It is safe, actually it is safe, but it is not recommended according to the guidelines. All the guidelines don't recommend the lysine. But if the patient already on it and get pregnant, I recommend stopping the lysine and increase dosage of levothyroxine.
Why it's safe, Dr. Khalid, pregnancy is hyperdynamic circulation as elderly people also for cardiac causes?
Yes, what, Dr. Nader?
Liothyronine in pregnancy, as we know that pregnancy is hyperdynamic circulation. Like combination therapy at this time may precipitate AF.
Actually, not for this point, Dr. Nader, but actually there is no sufficient studies to safety during the pregnancy, and because actually levothyroxine will be converted to T3 in peripheral tissue, so each levothyroxine will be converted to lysine. So, but the combination therapy during the pregnancy have no added value and no large studies showing safety of lysine for the fetus and the mother. So this is not indicated during the pregnancy.
Not examined, yeah. Okay.
Yes.
Shukran.
So I will try to cover this TSH-OMA guidelines published by the European Thyroid Association in 2013, and actually I will cover these guidelines again with the pituitary medulla, inshallah. And this is very important because in each exam they will ask a question about TSH-OMA, 1 or 2 questions. But when should TSH-OMA, which is TSH secreting pituitary adenoma, be suspected? If the patient presented with elevated thyroid hormone with non-suppressed TSH, TSH normal with elevation of thyroid hormone, or TSH is mildly elevated with elevation of the thyroid hormone. And in this situation, the first step is to exclude thyroid hormone interference. So, thyroid hormone interference must be ruled out before diagnosis of TSH-OMA. Why? Because thyroid hormone interference is more common than TSH-OMA. Thyroid hormone interference, like the anti-T4 and the anti-T3, or also abnormal form of albumin. And also, we should exclude the interference like the heterophil antibody. Finally, because patients that have undergone thyroid ablative therapy by mistake may present as a patient with unreasonable high TSH that the thyroxine replacement cannot restore, maintaining a normal free T4. So this is another indication to suspect TSH-OMA. Size, and usually the patient of TSH-OMA presented by mild manifestation of hyperthyroidism. How is TSH-OMA established? The first one is measuring TSH will be non-suppressed with elevation of the free thyroid hormone T4 and T3. T4 and T3, this is a very important, not free T4 alone. T3 and T4 must be elevated, and this is the hallmark of TSH-OMA. In MRI, most of the TSH-OMA are macroadenoma. A tumor size is more than 1 centimeter in about 80% of the patient, and usually in another situation may be presented as ectopic tumor. How to investigate biochemically by blunted TSH response to TRH stimulation, and we cover it in previous sessions actually, because this is the most important test, one of the most important tests for assessment of TSH-OMA versus resistant to thyroid hormone, which is presented in 90%. But complete inhibition of TSH following administration of T3 suppression test is also okay. Never reported in this patient, but usually occur in a patient with resistant to thyroid hormone. If we give T3 in a patient with TSH-OMA, TSH will not be suppressed. But in the normal physiological response, or a patient with resistant to thyroid hormone, TSH will be suppressed as normal. Another very important first test is alpha subunit, alpha glycoprotein hormone subunit, which be elevated in the TSH-OMA in about 70%, and also the most important is alpha glycoprotein subunit over TSH molar ratio will be elevated in about 80% of TSH-OMA. Another one, which is a parameter for thyroid hormone action, like for example sex hormone binding globulin and carboxy terminal cross-link peptide of type 1 collagen and other biomarkers. This is have a not a limited indication and not widely available, so there is a limited help in the diagnosis for TSHO. How to perform differential diagnosis with resistant to thyroid hormone? Usually the patient with TSHO presented by neurological signs and symptoms like a visual field defect, headache, because this is a macroadenoma, and a clinical feature like acromegaly or galactorrhea or amenorrhea, or if growth hormone or prolactin is co-secreted with TSHO. And this is an important test. A partial inhibition of TSH secretion after T3 suppression test is seen only in resistant to thyroid hormone. TSH response to TRH, a blunt response in TSHoma, and the preserved response in the resistant to thyroid hormone. And also resistant to thyroid hormone is inheritable disease, autosomal dominant, so it genetic mutation may be, if available, is presented in all of the cases of resistant to thyroid hormone versus TSHO. And also, if we give a chronic administration of long-acting somatotropin analog, this patient will respond and normalization of thyroid hormone with TSHO, but in a patient with resistance to thyroid hormone, not respond. So a somatostatin analog will control a thyrotoxic symptom in resistant thyroid hormone patient is not beneficial. It is beneficial only in the TSHO. And this is a very important algorithm to differentiate between resistant to thyroid hormone and the TSHoma. The first one, when you suspect resistant to thyroid hormone or TSHoma, if thyroid hormone is elevated with non-suppressed TSH, the first one is to exclude the thyroid hormone assay interference. So this is a case of central hyperthyroidism. What is the test is doing? If we do pituitary MRI and we find normal, this is mostly with resistant to thyroid hormone, but if it is abnormal, so it will be suggestive of TSHoma, but don't forget that it may be non-functioning pituitary adenoma incidentalloma. If we do, there is a family history of the disease, this is with resistant to thyroid hormone, but if no family history, it may be TSHoma. If we're doing, for example, alpha glycoprotein subunit over TSH molar ratio, and I cover it very different times in previous sessions. If it is normal, this is with resistance to thyroid hormone. If it is elevated, it is with TSHO. If we're doing TRH test, if it is a blunt response, it is with TSHoma. If it is increased, this is a resistant to thyroid hormone. If we're doing T3 suppression test, and I gave previously the protocol for doing this test, if it is a suppression, a decrease of the TSH, this is with resistance to thyroid hormone. If it is no response, it is a TSHO. If we're doing thyroid hormone receptor beta gene, this is a mutation gene with resistant to thyroid hormone, it is negative, it is a TSHO. So this is a very important algorithm, but don't forget the best one to differentiate between resistant to thyroid hormone resistance and TSHO is alpha subunit. The best biochemical test is elevation of the alpha subunit, and actually this table we cover it a lot of time from the Oxford Handbook, the 3rd and 4th edition. Why sex hormone binding globulin is elevated in TSHoma? I don't know, Dr. Sadia. So sex hormone binding globulin is elevated in the TSHoma, but not elevated in resistant to thyroid hormone. How to manage? What is the optimal treatment for TSHoma? What is the optimal treatment of TSHoma? Usually surgery. Surgical removal of the adenoma is the first line therapy with a transsphenoidal or subfrontal adenomectomy. But don't forget that no more than 60% of the patient with macroadenoma may be cured. So the failure rate is about 40%. If surgery and medical treatment are contraindicated or declined, pituitary fractionated stereotaxic radiotherapy or radiosurgery. الميديكال treatment, the only available medical treatment of TSHOMA is somatostatin analog. But actually, if a dopamine type 2 receptor are present in most TSHOMA, in this situation, a dopamine agonist like bromocriptine or cabergoline may be used for treatment in this situation if prolactin is elevated. How to prepare the patient for neurosurgery, because this is a very important issue. How to prepare the patient for neurosurgery. Here he mentioned in the guidelines an anti-thyroid drug, mesimazole or propylsulfuracil or somatostatin analog such as ectrodotide and lanreotide along with propranolol should be administered in order to restore euthyroidism before surgery. So he mentioned here an anti-thyroid drug, a somatostatin analog can be used to restore euthyroidism before surgery. But if we see Oxford Handbook, and I will go to actually to the third edition. You will find that they mention that carbimazole is not candidate. Carbimazole is contraindicated. Here, the second hyperthyroidism. This is Oxford Handbook. How to treat. Common feature of tachycardia. Okay. This is one.
Dr. Khalid, right in the chapter, pituitary chapter.
Between pituitary chapter?
Yes.
Okay. But I think here, okay. Okay.
Hyperfunction of thyroid gland.
Yes.
Next. After cushioning. Yes. This page, doctor.
This one?
I think.
This is no, not here actually, not here. This is a non-functioning pituitary
After non-function. After.
This
after
I think this is I think after gonadotrophin.
Yes.
This is one.
Yes.
So
Yes.
he mentions this. In management, they mention that the treatment with anti-thyroid drug has been associated with increased TSH in approximately 65. It should be avoided. So in the Oxford Handbook, they mention that the anti-thyroid medication should be avoided. But actually in the guidelines, they mention that the anti-thyroid drug can be used or somatostatin. So I will go to the pituitary book, which is Shalmo Melmed. This is a very important book, and since a few weeks, the 5th edition is published, and this is from the chapter 18. To be sure that the medication. Here, Shalmo Melmed or Yuna Greenman, the editor of this chapter, mentions that preoperative medical therapy is indicated to restore euthyroidism before surgery. This can be achieved with short-term treatment with anti-thyroid drug or somatostatin analog. But when using an anti-thyroid drug, which used to reduce the thyroid hormone level at least temporarily in the most patient, but it is importantly, all therapy directed to the thyroid gland result in increased TSH secretion by pituitary gland, and in the long term carry the potential risk of causing tumor expansion. This is a very important head. So if we give anti-thyroid drug just for a short duration, if we give it for longer duration, it will lead to expansion of the tumor, which will have a bad effect for the patient. So as such, a direct anti-thyroid treatment should be avoided, reserving the use of anti-thyroid drug only for short-term preparation before pituitary surgery. And actually, this is a very important thing, because this is some confusing point when reading the guideline.
If it's a question in the exam, Dr. Khalid,
Somatostatin analog. I will go to somatostatin analog.
yes.
If somatostatin analog is available, so this is the best option. But if no somatostatin analog and ask about the preoperative management and no other options than الكربيمازول, I will choose carbimazole. But actually, somatostatin analog is the best one. Yes, Dr. Najah mentioned that in another last edition. Now we can go to the last edition, Oxford Handbook. They mentioned page this is one. Actually, actually, this edition, fourth edition of Oxford, the paging numbers is not accurate enough. So this is this Chomal medical somatostatin analog. He mentioned that somatostatin analog as a medical therapy is the best one. The surgery, of course, the first line therapy is surgery, but during pre-operative preparation, somatostatin analog. And mentions that the anti-thyroid drug treatment with anti-thyroid drug has been associated with increased TSH. It should be avoided again, the same as for third edition. So actually, I Zoom still have some time and Salat al-Maghrib is still few, so we can cover this guidelines, subclinical hypothyroidism, and take a rest after subclinical hypothyroidism. The management of subclinical hypothyroidism is important because at the first, to diagnose subclinical hypothyroidism, we should know that the most common cause of persistent subclinical hypothyroidism is autoimmune thyroiditis, Hashimoto thyroiditis. So, TPO antibody are the most sensitive serological test for thyroid autoimmunity in subclinical hypothyroidism. Serum concentration of anti-TPO may wane over time. Repeating anti-thyroid antibody measurement don't enhance the monitoring of individuals of subclinical hypothyroidism patient. So, the same as a nice recommendation, repeating anti-TPO is not recommended, even if TPO is positive or negative. There are two categories of subclinical hypothyroidism: mild increased TSH between 4 and 10. This is a mild form of subclinical hypothyroidism, and a more severe increased TSH more than 10. So if TSH is more than 10, this is a severe form and require treatment for the young person. An initial raised serum TSH with a 3 to 4 within the reference range should be investigated by repeating measurement of both serum TSH and the 3 to 4 along with thyroid autoantibody, preferably after 2 to 3 months. Individuals who have positive anti-TPO or thyroglobulin antibody or have hypoechoic or inhomogeneous echo pattern should assess TSH. So if you do thyroid sonography and find that the patient thyroid gland is hypoechoic, in this situation, I must assess it by TSH. If the patient presented by positive anti-TPO, in this situation, I should order TSH. Who to treat and when to treat and who to observe. If TSH is less than 10 with symptoms, I will give a trial of levothyroxine for young patient. But don't forget that there is a limited evidence for improvement in mental function with levothyroxine for this age. Following hemothyroidectomy, persistent subclinical hypothyroidism should be treated as we discussed previously. Also, if the patient is presented by diffuse or nodular goiter with subclinical hypothyroidism, should be treated. Don't forget that obesity, body weight, not well improved if TSH is less than 10. Because we see a lot of cases of subclinical hypothyroidism and the patient main complaint is obesity. and the TSH is less than 10. The treatment of this patient by levothyroxine, the body weight will not respond. Don't forget that in type 1 diabetes mellitus, TSH should be monitored once yearly. In type 2 diabetes, we only indicate doing thyroid assessment if there is unexplained change in glycemic control by doing TSH and free T4, which should be measured. Levothyroxine will reduce the level of total and total cholesterol and LDL cholesterol, and also the effect of levothyroxine will be more pronounced in patient with pre-treatment if the serum TSH is more than 10. Even in the absence of the symptom, levothyroxine is recommended if TSH is more than 10, and I will cover this by very important algorithm. Don't forget that an age-specific reference range is very important in the elderly. And of course, for the elderly, if TSH is less than 10, no indication for treatment, just wait and see strategy is the best strategy for avoiding hormonal. Please avoid hormonal treatment if the patient is elderly, if the TSH is less than 10. How to treat? Of course, how to treat. If the decision is to treat, levothyroxine is the only available drug. No evidence to support liothyronine T3. For patients without cardiac disease, a weight-related dose of levothyroxine should be used, approximately 1.5 microgram per kilogram per day, but actually we can use a dose less than this. And usually we start by 75 microgram for women or 100 microgram for men, but actually in clinical practice we can start by dose less than this according to the TSH. If it TSH more than 10, I will start by this dose. If TSH is less than 10, I will start for male and female by about 50 microgram levothyroxine. And if anti-TPO is positive, I can start by 75 microgram per day. For patients with cardiac disease and elderly, a small dose of levothyroxine should be started at 25 to 50 microgram per day, and those should be increased every 2 to 3 weeks. And this is very important. Levothyroxine should be taken on empty stomach, either first thing in the morning or at bedtime, 2 hours or more after the last food. And don't forget that medications that interfere with levothyroxine like calcium, iron, proton pump should be taken at least 4 hours or more after levothyroxine dose. The serum TSH should be rechecked 2 months after changing the levothyroxine dose. The aim for the most of the adult, lower half of the normal. Between 0.4 to 2.5. This is the target TSH for the management of a case of subclinical or overt hypothyroidism. In the elderly, any treatment of subclinical hypothyroidism should be individualized and gradually and closed monitored. For the older patient more than 70 years of age, a higher treatment target for serum TSH around 1 to 5 is for patients with mild subclinical hypothyroidism, TSH is less than 10, who have been started with levothyroxine for symptoms, should reassess after 3 to 4 months, and if there is no improvement, I will stop levothyroxine. How to follow up of patient with untreated patient of subclinical hypothyroidism? If thyroid function has normalized following individual initial abnormal serum TSH, no further testing is required. Once the patient is asymptomatic, no thyroid autoantibody, don't have a goiter. In this situation, no need for follow-up. But if there is a persistent subclinical hypothyroidism, we should reassess thyroid function test after 6 months for the first 2 years and then yearly thereafter. Follow-up of a treated patient after normalization of the TSH, as the patient already in the levothyroxine, we should doing TSH annually. And this is the last slide in this topic. Actual subclinical hypothyroidism, how to treat. If the patient age is less than 70, In this situation, if TSH is more than 10, I will treat. If TSH is less than 10, if there is a hypothyroid symptom, I will treat for a 3 months trial and reassess. If no symptoms for the patient is less than 70, I will observe and repeat thyroid function test after 6 months. This is for patient less than 70 years of age. But for the elderly, if the serum TSH is less than 10, just observe and repeat testing after 6 months. If the serum TSH is more than 10, I will consider treatment only if clear symptom of hypothyroidism or high vascular risk. This is a very important slide when to manage subclinical hypothyroidism according to the European Thyroid Association guidelines. If anyone has any question about this topic.
دكتور خالد لو سمحت
Yes.
الانتر اكشن احنا عارفين انه الليفوسايروكسين بيتاخد on empty stomach.
Yes.
If I have one patient with hypothyroidism and treated for type 2 diabetes وكومنسد ريبيلساس مثلا الجي ال بي 1 ريسبتور اجونست اللي هو السيماجلوتايد يتاخدوا ازاي؟ يعني في any recommendation clinical في الحته دي ولا؟
The only recommendation is to take levothyroxine before the breakfast by 1 hour. If we give levothyroxine at bedtime at least 4 hours or 3 hours from the last food. The most important الكالسيوم الارن بروتون بامب الساكرالفيت الكوليسترامين must be apart from levothyroxine by 4 hours at least. This is the most important. Other than this you can do anything.
يعني ممكن نعمل combination ما بينهم عادي.
Yes, 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 yes.
Yes. شكرا.
دكتور خالد.
No, not for pediatric. This is not for pediatric patient for subclinical hypothyroidism. This is for adults. And actually this is for adults. Okay. This is for management of subclinical hypothyroidism because there is another guidelines actually published by the ETA for children, but minimal difference actually. Yes?
Yeah, Dr. Khalid, if I have a patient with subclinical hypothyroidism, for example, TSH20, and he's going for surgery with the general anesthesia, can I give him a clearance or I should postpone the surgery?
According to the surgery, if it is elective surgery, I recommend postpone. But if it is emergency, I will go to the surgery. But for elective surgery, it is preferred to postpone it until the normalization of thyroid function test. And this is a very important guidelines published by European Thyroid Association about the diagnosis and the management of endogenous subclinical hyperthyroidism and published in 2015. And the most important endogenous means exclude the exogenous hyperthyroidism which is caused by heterogenic levothyroxine. So the most important, the etiology is very important to and differential diagnosis of subclinical hyperthyroidism. The most important that new endogenous causes of subclinical hyperthyroidism usually Graves' disease, toxic adenoma, multinodular goiter, toxic multinodular goiter. And we should search for exogenous causes of hyperthyroidism like excessive thyroid hormone replacement therapy. For example, some patients receive levothyroxine high dose and after 6 weeks doing TSH will be low. This is exogenous cause of subclinical hyperthyroidism. The cause of transient subclinical hyperthyroidism, for example, if we treat a patient with Graves' disease by antithyroid drug, TSH will be low for long duration. Or after treating with radioiodine ablation, the patient will be persistent hyperthyroidism for long duration. Another very common causes of hyperthyroidism is transient hyperthyroidism, is subacute thyroiditis, painless or silent thyroiditis. In early stage of thyroiditis, the patient usually presented by subclinical or overt hyperthyroidism, and this will be transient and treated just asymptomatic treatment may indicate beta blocker, not more than a small dose of beta blocker. And very important to search for other causes of low TSH without hyperthyroidism. And this is usually due to, for example, central cause of low TSH, like pituitary or hypothalamic insufficiency, bad hypopituitarism, for example. And this is usually can be diagnosed from a clinical and history of the patient. If the patient, for example, presented by brain tumor, for example, in this situation, and after doing TSH, which will be low, in this situation, I must suspect it may be pituitary or hypothalamic lesion. Another cause is psychiatric illness. Some of psychiatric illness can be presented by low TSH. Also, a lot of drugs can decrease the TSH. For example, high dose of corticosteroid, dopamine, and amiodarone, lithium can decrease the TSH. Another cause of low TSH is severe non-thyroidal illness syndrome or non-thyroidal illness syndrome or sick idiothyroid syndrome, in which is known as low T3 syndrome or low T3 syndrome or non-thyroidal illness. In this situation, T3 will be low, T4 usually will be low, and TSH usually low or low normal. And also, the first trimester during normal pregnancy, TSH will be lower than a non-pregnant female. And in the first trimester, usually TSH may be low or suppressed and still represent a normal pregnancy. And also, low TSH may be presented in a black individual or during with smoking. TA, it is a toxic adenoma. So, endogenous cause Graves' disease, toxic adenoma, or multinodular toxic goiter. This is a three most important causes of endogenous hyperthyroidism, and I will discover these three disorders because the treatment of these disorders is different. Graves' disease can be managed by medication, carbimazole, or radioactive iodine or surgery, but toxic adenoma or multinodular toxic goiter must be treated definitely by surgery or radioactive iodine ablation. This is very important when we deal with subclinical hyperthyroidism, persistent subclinical hyperthyroidism. We have three levels of assessment. The level 1 is to establish and diagnose persistent subclinical hyperthyroidism. How we diagnose persistent subclinical hyperthyroidism? By doing TSH, free thyroid hormone or total thyroid hormone. If TSH is low, the next step is doing free T4 with total or free T3. The second level, and this is very important to establish the etiology of subclinical hyperthyroidism. How we can differentiate between a Graves' disease and toxic adenoma or toxic multinodular goiter? By doing thyroid sonography, by doing thyroid scan, by doing TSH receptor antibody, which is pathognomonic for Graves' disease. Level 3 to establish the risk associated with subclinical hyperthyroidism and appropriate treatment, and this can be detected by, for example, if we suspect heart or arrhythmia, cardiac arrhythmia, we should doing ECG, Holter, echocardiography. If we suspect osteoporosis, we should doing bone mineral density or DEXA scan. Also, CT scan or MRI scan can be used for detection of compression or retrosternal goiter. So the recommendation, the first one is to establish the diagnosis of persistent subclinical hyperthyroidism, and usually we mention that subclinical hyperthyroidism, we should label it as persistent subclinical hyperthyroidism. So TSH is the first and initial screening test for primary thyroid disorder. And we can classify subclinical hyperthyroidism according to the TSH into two types. Of course, TSH is low with normal T3 and T4. Grade 1, this is a mild form of subclinical hyperthyroidism or grade 1. Grade 1, TSH between 0.1 to the lower limit of the reference range, which is here 0.4. So 0.1 to 0.4, this is the grade 1 subclinical hyperthyroidism. A grade 2 in which TSH is less than 0.1, and this is a severe form of subclinical hyperthyroidism. The causes of transient TSH or subnormal TSH must be excluded. Pituitary or hypothalamic, psychiatric illness, non-thyroidal illness, drugs. And in this situation, we should retest a thyroid function test within 2 to 3 months to define it as a persistent subclinical hyperthyroidism. So if any patient presented with low TSH, in this situation, we should retest again after 2 to 3 months. If it is still low, in this situation, this is a case of persistent subclinical hyperthyroidism, and I will go to the establish the etiology. How to establish the etiology? As I mentioned previously, differential diagnosis mainly Graves' disease, toxic adenoma, toxic multinodular goiter. So scintigraphy or thyroid scan should be performed in nodular goiter with a grade 2 subclinical hyperthyroidism. Ultrasonography with color flow Doppler should be helpful, could be helpful with subclinical hyperthyroidism with nodular goiter. TSH receptor antibody, which is unique for Graves' disease, confirm the etiology of autoimmune induced hyperthyroidism. To establish the appropriate treatment, CT scan without contrast. This is for compression, for large multinodular goiter, and compressive symptoms. In this situation, CT scan is indicated. To assess the risk associated with subclinical hyperthyroidism, if we suspect heart failure, or arrhythmia, or coronary heart disease, we should go doing ECG, Holter ECG, and Doppler echocardiography. And this is only indicated in selected patient with a grade 2 subclinical hyperthyroidism. Also, in a patient presented with a grade 2 subclinical hyperthyroidism, TSH is less than 0.1, and postmenopausal women, elderly, and patient with risk factor for osteoporosis, we should doing bone mineral density or DEXA scan. And this is a very important algorithm for management of subclinical hyperthyroidism according to the guideline. Any patient present with low TSH, in this situation, I should go to clinical history and physical examination and assess free T4 with a free T3 or total T3, exclude the other cause of low serum TSH that are not subclinical hyperthyroidism. Also, we should exclude drug-related disorders, for example, amiodarone or lithium or dopamine or corticosteroid, and classify our patient into two categories. A grade 1, which is a TSH, is mildly low TSH. This is a TSH between 0.1 to 0.4. And in this situation, I will repeat a TSH after 3 to 6 months. If transient suppression, so no treatment. If persistent grade 1 subclinical hyperthyroidism, I should investigate by thyroid sonography, thyroid scan, TSH receptor antibody to differentiate between Graves' disease and toxic adenoma or toxic multinodular goiter. If Graves' disease, patient older than 65 with cardiovascular risk factor or comorbidity, in this situation, I will treat by carbimazole. So, for patient with Graves' disease and the grade 1 subclinical hyperthyroidism, older patient more than 65 years of age with cardiovascular risk factor or comorbidity, I will treat by antithyroid drug. For younger patient less than 65, if asymptomatic, just observe and reassess thyroid function test after 6 to 12 months. If symptomatic, I will give beta blocker alone. So this is very important. So for Graves' disease and the grade 1 subclinical hyperthyroidism, I will treat by carbimazole only for elderly patient with cardiovascular disease or risk factor or comorbidity. But for younger patient, if asymptomatic, just observe. If symptomatic, give beta blocker and follow up. For toxic adenoma or toxic multinodular goiter, If the patient is less than 65 years of age and symptomatic, I will start beta blocker. If with heart disease or cardiovascular disease or AF, I will give radioactive iodine ablation therapy. Also, for the patient older than 65 years of age with heart disease or cardiovascular disease or comorbidity, I will treat by radioactive iodine alone. So, toxic adenoma, but if radioactive iodine is not appropriate in this situation, beta blocker antithyroid drug is the next step. So this is for grade 1 subclinical hyperthyroidism, which is a mild form of subclinical hyperthyroidism. What about if TSH is less than 0.1? This is a situation grade 2 subclinical hyperthyroidism, and in this situation, I will do radioactive iodine ablation with a TSH receptor antibody, persistent subclinical grade 2 subclinical hyperthyroidism. If Graves' disease, in this situation, if the patient is more than 65, I will treat by medication, radioactive iodine, or surgery. Don't forget that if here, a grade 1, I will treat only by antithyroid drug. But for a grade 2 and the patient is more than 65, I will treat by radioactive iodine, surgery, antithyroid drug. For patient less than 65, if asymptomatic and grade 2, observe and reassess after 3 to 6 months, not 6 to 12 months like grade 1. If symptomatic, asymptomatic, observe. If symptomatic, I will treat by antithyroid drug and beta blocker here, just beta blocker, but grade 2, I will treat by antithyroid drug with beta blocker. If cardiac disease or morbidity, I will treat by antithyroid drug or radioactive iodine or surgery. This if the etiology is a grave disease. But if etiology is toxic adenoma or toxic multinodular goiter, if the patient is less than 65 of age, I will treat by radioactive iodine or surgery. If more than 65 of age, I will treat by radioactive iodine or surgery the same. So, for the patient with toxic adenoma, even younger or elderly patient must be treated by radioactive iodine or surgery. And of course, we can give antithyroid drug as a preoperative assessment. If we start antithyroid drug, we should start by very low dose of methimazole, 5 to 10 milligram daily. Not to start by a high dose of carbimazole, because if we start by a high dose of carbimazole, the patient will be iatrogenic hypothyroidism. A pre-treatment with methimazole before radioactive iodine or surgery might be considered in patients older than 65 of years with cardiovascular disease, either AF, coronary heart disease, or heart failure, because to decrease a risk of complications or worsening of hyperthyroidism. So this is the last slide in this guideline, and the most important slide in the guideline. This is the algorithm. This is the most important algorithm to differentiate between grade 1 of subclinical hyperthyroidism and the grade 2, and how to treat even if for the patient with grave disease and patient with toxic adenoma or toxic multinodular goiter. So the most important markers to differentiate between them: الاتيولوجي, grave disease, toxic adenoma, الage, the grade of subclinical hyperthyroidism, and the age. For the young patient, we can observe or treat by beta blocker, or here treat by beta blocker or antithyroid drug if the patient is symptomatized. Thanks, Dr. Ashraf. This is a very important slide. This is just summarize how to manage all cases of endogenous subclinical hyperthyroidism. So I will go to a next very important guidelines. This is guidelines published 2018 about checkpoint inhibitor. And actually, in every exam, they will ask 2 questions about checkpoint inhibitor, and this guidelines published by Society for Endocrinology and Endocrine regarding endocrine emergency guidance, acute management of endocrine complication of a checkpoint inhibitor. Checkpoint inhibitors, this is a very important immunotherapy used for treatment of mostly advanced cancer or metastatic cancer, either melanoma, non-small cell lung cancer, metastatic melanoma, and so on. There are two very important groups of checkpoint inhibitor, CTLA4 inhibitor like ipilimumab, and another one which is PD-1 inhibitor like nivolumab and pembrolizumab. This is the two classes of checkpoint inhibitor. And immune-mediated endocrinopathy or side effects of this medication, usually hypophysitis, adrenalitis, thyroiditis, and diabetes mellitus. This can be life-threatening if not recognized and treated appropriately. And early recognition and appropriate management of this endocrinopathy is essential. So these guidelines will be covered with pituitary disorder, with adrenal disorder, and today with thyroid disorder, because hypophysitis, adrenalitis, thyroiditis, and also diabetes mellitus is the most common endocrine-related side effects. And actually, this is not from the guidelines, this is from a paper, and actually I present this slide in a previous session from the immune checkpoint inhibitor long-term complications toxicity, and you will find that the possible frequency of a chronic autoimmune checkpoint inhibitor more than 80 to 100% side effect, usually hypophysitis, thyroiditis, hypothyroidism, adrenal insufficiency. Another side effects like, for example, arthritis, pneumonitis, esophagitis, vitiligo, pruritus is less than this very high percentage of endocrine-related side effects. So, a checkpoint inhibitor side effects mainly endocrine disorder. And the guidelines is differentiate between life-threatening side effects and mild to moderate, not life-threatening side effects. And actually, the most important side effects is adrenalitis, hypoadrenalism, which is maybe life-threatening condition. And I will cover this portion with adrenal disorder and pituitary disorder. But today, inshallah, I will cover only thyroid dysfunction. So what about life-threatening thyroid dysfunction? Actually, thyroid storm or myxedema is very, very rare with a checkpoint inhibitor, but can be treated if occurred the same as thyroidal storm or myxedema coma. But don't forget that thyroxine should never be instigated unless cortisol deficiency is excluded. If you cannot exclude cortisol deficiency, please give corticosteroid with thyroxine. Give corticosteroid before thyroxine. And how to manage mild to moderately unwell patient presented with a clinical feature compatible with endocrinopathy. I will cover thyroid dysfunction only because the cortisol and the diabetes will be covered in their section. The most common checkpoint inhibitor endocrinopathy is thyroiditis. And this is usually a transient hyperthyroid stage, may not be symptomatic, followed by permanent subclinical or overt hypothyroidism. The thyrotoxic phase of thyroiditis should be managed symptomatically with beta blocker. And the glucocorticoid and the antithyroid medication is if no value. So, the thyrotoxic phase of thyroiditis should be managed by only beta blocker. Levothyroxine should never be instigated until coexisting cortisol deficiency is excluded or treated. Immunotherapy can be continued once patient is clinically stable on appropriate endocrine therapy. And actually, this is a very important algorithm to about how to manage a patient with mild to moderate symptomatic thyroid dysfunction presented as a side effects of a checkpoint inhibitor. Of course, as I mentioned every time, TSH is the gold standard test. If it TSH within the reference range, in this situation, I will do free T4. If it is above the reference range, this patient represents usually assay interference. We should repeat thyroid function test. If remain abnormal, we should refer the patient to endocrinology clinic. If the free T4 is low, below the reference range, in this situation, I will suspect hypopituitarism and I must exclude the adrenal insufficiency and hypopituitarism. So I will go to the cortisol algorithm and manage a case according to the cortisol insufficiency. So if TSH is normal with low free T4, I must exclude hypopituitarism. If free T4 is elevated, I will repeat thyroid function test if remains abnormal in this situation. This is usually central hyperthyroidism, not related to checkpoint inhibitor, or resistant to thyroid hormone, not related to checkpoint inhibitor, but the most common is assay interference. If TSH is elevated above the reference range, this is a case of usually I will go to free T4. If it is within the reference range, this is a subclinical hypothyroidism. If the patient is symptomatic and the TSH is more than 10, I will give thyroxine. If asymptomatic, I will repeat and consider thyroxine if TSH is more than 10 twice. And if we start by levothyroxine, I will start by a small dose, 75 microgram, unless history of AF or ischemic heart disease, in which situation I will start by a small dose, 25 microgram, not 75 microgram. If free T4 is low, this is a case TSH is low and elevated with low free T4. This is overt primary hypothyroidism. If the patient is symptomatic, I start with levothyroxine 75. If asymptomatic, I will repeat thyroid function test and I will start if TSH is more than 10 twice. And I will start by the same dose. So this is a case of hypothyroidism causing by a checkpoint inhibitor drug. If TSH is low, this is a case of thyrotoxicosis. I will go to the free T4, which if it is above the reference range, this is a hyperthyroidism, probably secondary thyroiditis. As I mentioned previously, if symptomatic thyroiditis, I will give beta blocker. If persistent symptom, consider autoimmune thyrotoxicosis like Graves' disease, and I will check for TSH receptor TSH receptor antibody or thyroid scan. If no symptoms, just repeat thyroid function test with subsequent checkpoint inhibitor cycle. If TSH is low with low free T4, in this situation, I must suspect hypopituitarism. I will check 9 AM cortisol, morning cortisol, and if it is low, this will diagnose central hypopituitarism, and I will treat as a central hypopituitarism by replacement therapy of corticosteroid, by replacement therapy as central hypothyroidism. And this is a very important slide for management of patients with mild to moderate symptomatic thyroid dysfunction with checkpoint inhibitor. And actually this table, this figure from this paper, not from the guidelines, and actually I mentioned it in the thyroiditis session for CTLA4 inhibitor, which drug, and the most common side effects with CTLA4 inhibitor is hypophysitis, and the most common side effects with PD-1 inhibitor like nivolumab, thyroid dysfunction and thyroiditis and hypothyroidism. And also this is from another very important paper, endocrine toxicity of immune checkpoint inhibitor, because this is a very important topic. And I actually cover and I discuss this table previously in thyroiditis session, and this summarize all checkpoint inhibitor endocrine related side effects and how to manage and how to assess, for example, pituitary or anti-pituitary side effects, which is more common with CTLA4 inhibitor. I will affect the hormone excitation, TSH, hypophysitis, and how to treat prednisolone and methylprednisolone, and symptomatic if the symptoms are severe, and so on. And also thyroid function is common with PD-1 and PD-L1 inhibitor, and supportive management if thyrotoxicosis, and if hypothyroidism, I will treat by levothyroxine if TSH is more than 10 by the same dosage like overt hypothyroidism, 1.6 microgram per kilogram starting dose. And also the pancreas can be affected by PD-1, PD-L1 inhibitor and causing what is known as ICI diabetes or insulin associated diabetes immune immune checkpoint inhibitor associated diabetes mellitus, and this is treated as type 1 diabetes by basal bolus insulin therapy. And also adrenal disorder, which is very common with dual therapy with CTLA4 or BDA1 and cause primary adrenal insufficiency and treated by, and this is a life-threatening condition and should be treated by glucocorticoid replacement therapy. And this actually is the last slide in this topic. And I will go to next one of the most important guidelines for central hypothyroidism. And actually central hypothyroidism, I will cover it with pituitary chapter inshallah, but this guidelines is important, and actually I have a presentation in ThyroAlex about central hypothyroidism, and this guidelines is published in 2018. And the first important, this table is important because gene, this is inheritable form of central hypothyroidism. And what should you know that two gene defect BOF1 and the PROB1, because actually in the exam they will ask a question about BOF1 and the PROB1. In the previous exam they ask a question about this gene defect in the pituitary disorder, and I will discuss it in the pituitary disorder. BOF1 gene defect, this is usually a dominant or recessive inherited central hypothyroidism and usually combined growth hormone and the prolactin defect. The prolactin will be low, growth hormone deficiency with central hypothyroidism. And the PROB1 gene defect, this is a recessive inherited central hypothyroidism and usually combined with growth hormone, prolactin and gonadotrophin defect. So this is how to differentiate between BOF1 and the PROB1. The PROB1, growth hormone, prolactin and gonadotrophin deficiency with hypothyroidism, central hypothyroidism. But BOF1 combined the growth hormone and the prolactin defects with central hypothyroidism. So the gonadotrophin deficiency will be manifested in a PROB1. Another one which is unique for Kallman syndrome, and this is also will be discussed with the pituitary chapter, FGFR1, which is dominantly inherited Kallman syndrome, which presented with central hypogonadism and anosmia, and FGF1, which is recessively inherited Kallman syndrome. And this gene defect is important because in the exam they will ask a question about this gene defect. And what is the cause of central hypothyroidism? As you know that any invasive or compressive lesion in the pituitary cellular region can cause central hypothyroidism. Like for example, pituitary macroadenoma, even non-functioning pituitary adenoma, macroadenoma can cause central hypothyroidism. Craniopharyngioma, meningioma or glioma, thoracic cleft cyst, metastatic seeding, carotid aneurysm, and inshallah in the pituitary module I will cover this all these disorders, and we need to differentiate between this disorder by MRI pituitary, because in the exam they will give you an MRI pituitary and ask about diagnosis and how to treat. So you need to differentiate between MRI pituitary of craniopharyngioma and meningioma or thoracic cleft cyst and so on. Another cause of central hypothyroidism, iatrogenic cause, like for example cranial surgery or radiation, or some drugs like a retinoid or mitoten. Mitoten is very important drug, and we will cover it in the adrenal chapter and also in the adrenal chapter. Also, injuries can cause central hypothyroidism like head trauma or traumatic delivery, vascular accidents like pituitary infarction or Sheehan syndrome or subarachnoid hemorrhage. Another autoimmune disease can cause central hypothyroidism like postpartum hypophysitis and lymphohypophysitis, and this is very important in the exam, especially MRI pituitary causing lymphocytic hypophysitis, infiltrative lesion like iron overload or sarcoidosis or histiocytosis X, inheritable defect, and also infective disease like TB or syphilis can cause central hypothyroidism. Okay. Is it okay, Dr. Mahawish, my voice now? And this table is very important because can be misdiagnosed as central hypothyroidism, low TSH, and can be diagnosed by falsely as a central hypothyroidism. Non-thyroidal illness, isolated maternal hypothyroxanemia. In this situation, the mother represented by low free T4 with normal TSH and can be diagnosed wrongly as central hypothyroidism. This is isolated maternal hypothyroxanemia, and actually we cover this topic in the previous session when we discuss thyroid disorder with pregnancy. And also, after withdrawal of levothyroxine, the patient can be presented by low free T4 with normal TSH. And the recovery from thyrotoxicosis and also technically assay problem or interference can be presented by low TSH, low free T4 with normal TSH. And drugs that decrease TSH like glucocorticoid, dopamine, cocaine, anti-epileptic or antipsychotic metformin, also premature birth, delayed TSH rise in the hyperthyroid infants, and also a very important syndrome which is MCT8 mutation, which is known as Allen-Herndon-Dudley syndrome. Do you remember Allen-Herndon-Dudley syndrome or not? Actually, this syndrome, I discuss it in more details in the first session, and actually this is a syndrome presented by a male with severe psychomotor retardation with peripheral tissue hyperthyroidism. The patient usually presented by male because it is X-linked recessive, yes, MCT8 defect, TSH will be low, T4 will be low, elevation of the T3 with decreased reverse T3. And actually, I will just give this slide from this syndrome from the first session because I cover it in more details. When we cover this syndrome, this is important because we cover syndrome with impaired sensitivity to thyroid hormone, and I cover this syndrome which is related to MCT8 defect. This is the Allen-Herndon-Dudley syndrome, and I cover it and how to treat it by this slide in more details, and how to treat symptomatic treatment and levothyroxine with propyl thyroxine, combination with levothyroxine with propyl thyroxine, and another medication which is DETBA and Triac and Tetrac, which is not FDA approved for the management of Allen-Herndon-Dudley syndrome, and I cover this presentation in more details in the first session of this course. Another one which we should diagnose it correctly with is TSH beta mutation, which is conserved bioactivity but lost immunoreactivity of circulating TSH. And this is algorithm how to differentiate and how to diagnose and management of central hypothyroidism. And what is important diagnosis is usually by low free T4 with inappropriately low TSH. We should re-evaluate and confirm and exclude other conditions with similar biochemistry. And if in the newborn, we should treat as soon as possible. If there is a macroorchidism, this is a form heritable isolated central hypothyroidism, and we should go to the genetic analysis. If confirmatory test if not a newborn, and in which we should treat as soon as possible to avoid neurocognitive dysfunction. We should go to confirmatory test by doing, if there is a positive personal history or pituitary hypothalamic lesion, by doing some imaging study, and then we treat as appropriate of central hypothyroidism by levothyroxine. Are finding useful and supportive diagnosis of central hypothyroidism. This is very important. If there is evidence of first degree relative central hypothyroidism, this will confirm our diagnosis. If there is a delayed growth or macroorchidism or hearing loss, this will diagnose central hypothyroidism. Also, if there is insufficiency of other pituitary hormones, this will be sufficient to diagnose central hypothyroidism. Also, if there is a blunt or delay response, TSH response to TRH, in which TRH, if we inject TRH, TSH will be elevated. If TSH is not elevated by a peak response after 16 minutes, this will be diagnosis of hypothalamic lesion and diagnose central hypothyroidism. If blunt or nocturnal TSH, as we know that TSH has a nocturnal variability, nocturnal variability. If there is a blunted nocturnal TSH surge, this will be support diagnosis of central hypothyroidism. And lastly, if low TSH index, which is calculated from this equation. So, which patients are at risk of central hypothyroidism? We should consider diagnosis of central hypothyroidism if we find that FRET4 is low with normal TSH. Also, if there is a manifestation of congenital hypothyroidism in neonates, but low or normal neonatal TSH. As we know that screening program in most of our localities doing TSH, but if we see a typical picture of neonate with congenital hypothyroidism and the TSH is normal or low, in this situation I must suspect central hypothyroidism, and in this situation I must do FRET4. Another one, if we should consider central hypothyroidism if FRET4 is low with a slight elevation of the TSH but less than 10. But in this situation, this can be diagnosed as overt hypothyroidism. TSH is elevated, less than 10, but with low FRET4. How to differentiate between this with central hypothyroidism, between this central hypothyroidism with overt hypothyroidism? By another finding. For example, central pituitary lesion or a brain lesion or history of pituitary surgery or pituitary radiation or another thyroid hormone deficiency like central cortisol deficiency or central hypogonadism. In this situation, I will suspect central hypothyroidism. And also this can be more diagnosed as central if we're doing, for example, thyroid sonography and thyroid tissue are normal, or doing anti-TPO and anti-TPO is negative. In this situation, this criteria will be with central thyroid disorder, not overt hypothyroidism. And also, we should screen for central hypothyroidism for early children with familiar history of central hypothyroidism and or failure to thrive or developmental delay or growth hormone deficiency or delayed or precocious puberty. And also, we must check for IGSF1 defect if the patient presents with macroorchidism. And we recommend screening for central hypothyroidism for patients with a personal or family history of hypothalamic pituitary lesion, moderate to severe head trauma, stroke, cranial radiation, hemochromatosis. Metformin interfere with the TSH secretion. How frequent it will cause central hypothyroidism, and do we need to screen patient on metformin for low TSH? Actually, no. A risk of affection of the TSH secretion with metformin is very limited. So this is not recommended screening for long-term metformin. The only recommendation if the patient on long-term metformin is vitamin B12 deficiency, not TSH or central hypothyroidism. We recommend screening for central hypothyroidism in any patient with hypothalamic pituitary disease like hyperprolactinemia, acromegalic feature, diabetes insipidus, recurrent headache, visual field defect, newborn with hypotonia or prolonged jaundice. In this situation, I should screen for central hypothyroidism. How to be diagnosed low free T4 with TSH low or low normal or mild elevated, and in this situation at least two separate determination and after exclusion of other condition. Isolated finding of low free T3 or total T3 is not indicative of central hypothyroidism. So T3 has no role in diagnosing of hypothyroidism, either primary or central hypothyroidism. And the follow-up, this is a very important to how to follow up a patient with central hypothyroidism by free T4. So the free T4 is the only method for follow-up of the patient with central hypothyroidism. And usually we doing free T4 with TSH. If it TSH in a patient presented with central hypothyroidism and the pre-treatment will be normal and suppressed after treatment, you must suspect overdosage of levothyroxine. We can classify central hypothyroidism into two types: mild central hypothyroidism, in which borderline low free T4, and in this situation with inappropriately low TSH should be supported by combination of several other findings summarized in the previous table. For example, another anti-pituitary hormones to classify it or diagnose it as a central hypothyroidism. How to treat by levothyroxine is the first line therapy, and we treat central hypothyroidism only after exclusion of central adrenal insufficiency, because if coexistent central adrenal insufficiency is not ruled out, in this situation we must start after steroid therapy to avoid adrenal crisis. Congenital and severe forms of central hypothyroidism like TSH beta mutation, we should start levothyroxine as soon as possible at a doses used also for primary congenital hypothyroidism, usually by a very large dose, 10 to 12 microgram per kilogram body weight per day. This is the same dosage of congenital hypothyroidism. And in order to rapidly rescue serum free T4 level to normal range to avoid neuroconjunctive dysfunction. A milder form of congenital hypothyroidism, we suggest to start replacement therapy with small dose. This is for neonates, just 5 to 10 microgram per kilogram per day to avoid the risk of over treatment. This is a milder form of congenital central hypothyroidism. And the central hypothyroidism diagnosed during childhood or adolescence, we start by a dosage of levothyroxine between 3 to 5 or 2 to 20.4 microgram per kilogram per day, and this is for children. But for adults younger less than 60 years, we start by dosage of 1.2 to 1.6 like primary hypothyroidism microgram per kilogram per day. But for elderly patient more than 60, we start by small dose, start 1 to 1.2 microgram per kilogram per day, and we start by small dose and increasing dose every 2 to 3 weeks to avoid cardiac arrhythmia. And after starting levothyroxine, we should reassess our case after 6 to 8 weeks, like primary hypothyroidism, by doing free T4 and TSH measurement. And blood testing should be withdrawn before the morning sample, or at least 4 hours after the levothyroxine administration. And our target to maintain the free T4 above the median value of the normal range. So this is the target of free T4 above the median value of the normal range. Inshallah, this is the last one. I think within 20 minutes I will finish this session, and to continue inshallah not in the next Friday, in the Friday after the next one, because we have a conference ceremony inshallah in the next Friday. So I will continue after this few guidelines. I think 20 minutes, and I will stop this session inshallah, because I think we have a lot of remaining slides. We just admit of these guidelines. Yes, central hypothyroidism is very difficult subject, but by repeating it several times, I think it can be easy. So I choose the most important recommendation actually, and I think there are just a few slides, 1 or 2 slides. How to follow up after adequate replacement therapy by levothyroxine? The only test for doing annually is free T4 in adults. And of course, levothyroxine dosage need to be up titration in the following cases. If the child is still presented by cognitive development abnormality or retarded psychomotor, you must suspect that levothyroxine dose need to be up titration. If we start growth hormone replacement therapy, levothyroxine need to be increased. If we start estrogen replacement therapy for treatment of panhypopituitarism or delayed puberty, levothyroxine dose need to be increased. Puberty development, controlled ovarian stimulation, pregnancy, weight gain. In this situation, dosage of levothyroxine need to be increased. And also, if we introduce drugs that affect levothyroxine absorption, in this situation, we need to increase the dosage of levothyroxine, and also we should check free T4 and TSH after 4 to 6 weeks. And this is the last slide in this guidelines. We need to decrease the levothyroxine dose in the elderly, especially if presented with cardiovascular morbidity, and also after menopause, or if there is a significant weight loss. In this situation, we need to decrease a dosage of levothyroxine. And this is the last slide in this guideline, and I will go to rapidly to amiodarone associated thyroid dysfunction. This is a very important guidelines published by European Thyroid Association in 2018. So if anyone want any question about central hypothyroidism, it is welcome. Okay. Actually, central hypothyroidism, I cover it a lot of time, but this is a very important table. After receiving amiodarone, there are some affection of thyroid function test, TSH, and thyroid hormone, total or free T4, total T3 or free T3. Short-term therapy after receiving amiodarone for less than 3 months, TSH will be increased. The main pathogenomic feature is low T3. This is the first one. After that, T4 will be increased, then TSH will be increased. Later on, long-term therapy, TSH will be normalized, and T4 is still elevated, mildly elevated, with mild decrease T3. This is a very important. Why T4 is increased and T3 is decreased? Because amiodarone will inhibit the adenase type 1, which is responsible for hepatic conversion of T4 to T3. So T3 will be decreased, T4 will be increased due to the inhibition of hepatic deadenase type 1 activity. Target of free T4 for the central hypothyroidism, the upper half of the normal, and actually you missed it, Dr. Najah, because I mentioned it here in the guideline. This is one. Maintain free T4 above the median value of the normal range. This is our target. Maintain free T4 above the median value of the normal range. But actually, if TSH is detectable, we need to avoid a suppression of the TSH, because if the TSH is suppressed, this will indicate overdosage of levothyroxine. And actually, this is presented in the guidelines, but due to the time, I skip it. So, a short-term therapy and the long-term therapy of amiodarone is very important, because in this situation, we should differentiate between the side effects of the amiodarone and the amiodarone effect in the normal thyroid function test. Should all patients with amiodarone-induced hypothyroidism, AIH, this can be diagnosed as amiodarone-induced hypothyroidism. This is amiodarone-induced hypothyroidism. And should amiodarone be withdrawn in this patient? Most frequently, it develops in patients with underlying chronic hypothyroidism. No clear association between the daily or cumulative dose of amiodarone and consequence of amiodarone-induced hypothyroidism. Amiodarone-induced hypothyroidism is easily treated by levothyroxine, and no need to discontinue amiodarone if considered essential for the underlying cardiac disease. Subclinical amiodarone-induced hypothyroidism does not necessarily progress to overt amiodarone-induced hypothyroidism. Normalization of the free T4 and the free T3 level and maintain serum TSH level between the upper limit of the reference range or slightly below the upper limit. This is our target. Slightly elevated TSH less than 10. In the case of overt amiodarone-induced hypothyroidism, to avoid the risk of overt treatment. And of course, amiodarone-induced hypothyroidism does not require amiodarone withdrawal. How to treat? According to the underlying thyroid pathology. If it is autoimmune thyroiditis, we should treat by levothyroxine. If normal thyroid gland, can amiodarone be stopped or not? If we cannot stop amiodarone, we will give levothyroxine. But if we can stop amiodarone in this situation, I will reassess thyroid function test after 1 to 2 months. If the patient euthyroid, then follow up. If the patient is still hypothyroid, I will give levothyroxine. But don't forget that if TSH is more than 20, I will start by levothyroxine. If less than 20, I will reassess. In a case of overt hypothyroidism, I must treat by levothyroxine. If subclinical hypothyroidism and the TSH is less than 20, in this situation, if the patient is cardiac or have a high risk factor, in this situation, I will treat. If the patient is asymptomatic and no risk factor in this situation, you can just wait and see. And this is a very important table to differentiate between amiodarone-induced thyrotoxicosis type 1 and type 2. And as I mentioned previously, coronary flow Doppler sonography is the best modality to differentiate between type 1 and type 2. Type 1 increased vascularity, type 2 absent hypervascularity. Type 1, this is a form of Jod-Basedow effect, but type 2, this is a destructive thyroiditis. The next one after coronary flow Doppler sonography to differentiate between two types is thyroid radioactive iodine uptake. It is low or normal or increase in type 1, but it will be suppressed or near zero in type 2. Yes, amiodarone-induced hypothyroidism, as mentioned in Oxford Handbook, they mentioned to treat if more than 20. Yes, more than 20, and I will. We can go it for from the Oxford. This one, and actually from first third edition. To be sure, it is this is one congenital. This is one. So he mentioned here, levothyroxine replacement is almost always considered for those with serum TSH is more than 20. If TSH between 5 and 20, the value of levothyroxine replacement can be judged on a clinical ground, such as abnormality of diastolic function, which can be reversible. If serum F84 is below the reference range, then levothyroxine replacement is usually indicated. So this is a very important in amiodarone.
دكتور خالد تي اس اتش above 20 في الحاله دي بيبقى العيان عنده symptomatic hypothyroidism.
Even if the patient is not symptomatic.
Okay, but I'm talking about the diastolic dysfunction في العيان ده والريسك بنفيت equation. الهايبوثايروديزم develop diastolic dysfunction.
Yes, and in this situation, once the TSH is more than 20, I will treat, irrespective of other conditions. If the TSH is less than 20 and there is a cardiac abnormality in this situation, it is recommended to treat.
Okay.
So how to differentiate between type 1 and type 2, because the treatment is different according to the etiology. The current fluid Doppler is the best one. Thyroid radioactive iodine uptake is important, and don't forget that in our Oxford and Bog, they mentioned that radioactive iodine here in type 1 it is normal, but don't forget that the guidelines mention that radioactive iodine may be normal, may be low, may be increased in type 1. And in type 2, usually suppressed, usually near zero uptake. Of course, amiodarone use thyroid type 1 usually developed in abnormal thyroid gland, so you may find thyroid nodule or thyroid autoantibody or grave disease and so on. And don't forget that spontaneous remission is not occur in type 1. So in type 1, we should go after an antithyroid drug to definitive therapy by surgery or radioactive iodine, which is generally required. But for type 2, usually spontaneous remission will occur and definitive treatment is not required, because this is a question from some of my colleagues. How to treat type 1? Yes?
Clinical wise دكتور خالد في عيانين under amiodarone treatment type 1 post surgery يعني شفناهم قبل كده ولا يعني العيانين دول بنشوفهم ولا يعني
Yes, actually yes, this is a definitive therapy. Amiodarone use thyrotoxicose type 1 it treated first line therapy by carbimazole, but once you stop the carbimazole, thyrotoxicose will be relapsed. And in this situation, I must go to surgery or radioactive iodine ablation if there is radioactive iodine uptake, increased uptake. But surgery is the first option. Radioactive iodine ablation is suitable if there is sufficient uptake. But for type 2, the treatment is usually by glucocorticoid, and usually glucocorticoid for a short duration or some months, and once stopped, the patient will not relapse it.
الديسيشن هنا based on multi-disciplinary team between الكارديولوجيست والدوكرينولوجيست بناء على انه العيان مش didn't stop the amiodarone therapy, so
even if amiodarone, I will cover this in the next slide actually. So can amiodarone be continued in amiodarone use thyrotoxicosis? Actually, the diagnosis of amiodarone, this is very important, because in some cases of the amiodarone use thyrotoxicosis, the amiodarone can be continued. So the first hint I would mention is this, because this is a debatable point. In amiodarone use thyrotoxicosis, free T4 and free T3 must be elevated, not free T4 alone, like central hyperthyroidism. Free T4 and free T3 must be elevated in a very narrow or in a very small percentage, in a very severe non-thyroidal illness, T3 may be normal with amiodarone-induced thyrotoxicosis, but in most cases, free T4 and free T3 elevated with suppressed TSH. Can amiodarone be continued? This decision should be individualized with respect to the risk stratification, taken jointly by specialized cardiologist and endocrinologist. Amiodarone should be continued in a critically ill patient with life-threatening condition, cardiac arrhythmia. Continuation of amiodarone treatment is probably also feasible in type 2. Amiodarone can be continued. The problem is more complex in amiodarone use type 1. Many endocrinologists favor amiodarone withdrawal if feasible from the cardiological standpoint. So stopping amiodarone is feasible in type 1 after consultation with cardiologist. And this is very important algorithm to how to manage type 1 and type 2. Type 2, usually amiodarone can be continued. We give corticosteroid after a few times remission and just need a follow-up. But amiodarone use type thyrotoxicosis type 1, stop amiodarone if feasible after consultation of cardiologist. We give carbimazole with sodium perchlorate, and after the patient rendered euthyroid, we should go to definitive treatment by surgery or radioiodine ablation if suitable. But the problem here, in most cases, we cannot differentiate between type 1 and type 2. In this situation, this is a mixed 4. In this situation, I will give carbimazole plus glucocorticoid. If there is rapid response, in this situation, this is a type 2, and I will stop carbimazole. If no rapid response, in this situation, this is a type 1, and I will stop glucocorticoid and continue carbimazole. So this is a very important, because in the exam, they will give question like this, and if you start carbimazole and glucocorticoid in the patient, thyroid function test improved rapidly. Which type of amiodarone-induced thyrotoxicosis in this patient? This is a type 2. And in this situation, I will stop carbimazole, and actually we cover it several times previously, especially in a session of amiodarone, and we give a lot of question and solve a lot of question from different sources. And this is the summary for recommendation from the guidelines. Amiodarone-induced hypothyroidism don't require amiodarone withdrawal. Overt amiodarone-induced hypothyroidism should be treated by levothyroxine. Treatment can be avoided in some subclinical cases. A total thyroidectomy to be performed without delay in amiodarone-induced thyrotoxicosis patient with deterioration of cardiac function or severe underlying cardiac assessment. As I mentioned here, emergency thyroidectomy in selected cases. If there is a cardiac compromise, severe underlying cardiac disease, of course, surgery can improve the condition. In those patients whose thyrotoxicosis is unresponsive to medical therapy, surgery is suitable. And of course, an antithyroid drug is the most effective treatment for amiodarone-induced thyrotoxicosis type 1. First line treatment for type 2 is glucocorticoid. And don't forget, the decision to treat milder or subclinical form of amiodarone-induced thyrotoxicosis type 2 should be taken into your account underlying cardiac condition. In mixed or indefinitive type, we should start by combination with carbimazole with glucocorticoid from the very beginning, or after a period of 4 to 6 weeks of poor response remains to be established. Euthyroidism be restored before total thyroidectomy or radioactive iodine by carbimazole unless definitive treatment is urgent. In this situation, we will go to the emergency thyroidectomy. And actually, this is the last slide from the guideline. So I think Graves' hyperthyroidism is a big topic, so I will postpone it to the next session, inshallah, because I will cover Graves' hyperthyroidism and also pediatric Graves' hyperthyroidism. And also we have a lot of several guidelines. I will mention it so you can read it. Graves, hyperthyroidism, and pediatric Graves disease. And also I will cover thyroid dysfunction following immune reconstitutional therapy, and this is important in the exam. And also I will discuss Graves' orbitopathy, and also I have iodine-based contrast media-induced thyroid dysfunction, because this is a practically important topic, so I will cover it. And also I will cover thyroid disorder prior to and during assisted reproductive technology. And actually this is the last guidelines I will cover inshallah in the next session. Inshallah the next sessions, not the next Friday, but the next after 2 weeks from today inshallah. So if anyone has any question, it is welcome.
دكتور خالد معلش سؤال اخير بخصوص الاميودرون انديوزد سيروتوكسيكوزيس او هايبوثايروديزم. all for recommendations based on chronic treatment of amiodarone, is there any recommendation for acute cardioversion of VTAC, as we know that amiodarone have a very long half-life?
Actually, short use of amiodarone mostly have no effect, just will decrease the T3 with elevation of the T4 with mild elevation of the TSH, which need no treatment. So acute usage of amiodarone mostly have no effect. But actually before starting of amiodarone for non-emergent use, we should assess thyroid function status.
تمام.
Dr. Mahawish asked about the response to steroid plus anti-steroid drug. If rapid response, this is amiodarone use thyrotoxicosis type 2. In this situation, I must stop carbimazole and continue steroid. So, how to assess this? By doing T3 after 2 weeks. If T3 is decreased by 50%, this is a type 2, and we should stop carbimazole. If T3 is not reduced by 50%, in this situation, this is a type 1, and I must stop a gradual taking corticosteroid and continue carbimazole. And actually, I already send this to guidelines, these two collections. Part 1, which is continue the European and NICE guidelines, and the part 2, which is contains the American guidelines collection of thyroid guidelines. And this file actually is more than 800 papers. So inshallah in the next presentation I will continue cover of this guidelines, European guidelines. Actually, for how long we use steroid? Actually, within a few months, Dr. Asma, just 2 or 3 months. But we should stop corticosteroid by tapering the dose.
Just Dr. I want to ask about the effect of amiodarone on euthyroid patient as a normal effect of amiodarone.
Yes.
Is it limited to a period of time of using amiodarone, or can we still get side effects of amiodarone in a short period as well? And how do we differentiate between this and that?
Actually, this is actually I cover this in several slides, because short term it means within 3 months of using amiodarone. What is the dosage of amiodarone can cause side effects? I don't know, but actually 1 dose of the amiodarone, 200 milligram, this is a contain a lot of the amiodarone that can cause by check of effect amiodarone induced hypothyroidism, or basido can cause thyrotoxicosis. But usually thyrotoxicosis or hypothyroidism occur after 3 months of using of amiodarone, not less.
Dr. Khaled?
Yes.
I have a patient pregnant, okay, 36 weeks.
Yes.
The lab hyperthyroidism 0.01 TSH, free T4 normal up to 22, free T4 25. the patient referred from
So free T4 is normal or elevated?
just
Mild
slightly
elevation.
elevated.
Yes.
Yes, and the patient asymptomatic. A transfer from obstetrician to me to control the patient. The patient now asymptomatic. So the next step, by thyroid examination, no goiter, no thyroid, no any nodule. So the next step, thyroid ultrasound or start carbimazole.
لا, start carbimazole in this situation is not ideal. Actually, this is even if it is a grave disease, this is a mild form of a grave disease, in which a mild form of a grave disease can just be treated by wait and see. And this is actually mentioned in the American guidelines. A mild form of hyperthyroidism can be observed only. But if free T4 is elevated or the patient is symptomatic, in this situation, I will start by antithyroid medication.
No, doctor, the patient asymptomatic, but the lab hyperthyroidism.
Yes, I am with asymptomatic. I know this. This is just a mild increase of free thyroid hormone with low TSH. The patient is asymptomatic. In this situation, this is a mild form of a grave disease or a mild form of hyperthyroidism. In this situation, a risk of a drug is more than a risk of the disease.
Okay.
Okay.
So Dr. Wade,
And I will show it in this guideline. Actually, I can go to the guidelines, this American Thyroid Association. Pregnancy, this is one. And I will show it to you. This is while mild hyperthyroidism, I will mark it. This is one. Mild hyperthyroidism appears safe for the mother and fetus. So in this situation, no treatment for mild hyperthyroidism if the patient is asymptomatic. But moderate to severe hyperthyroidism can prove dangerous. And actually, in this situation, we should try to manage the patient according to the risk of the treatment and the risk of the disease. If you can wait and see, this is the most important step in this situation. Yes, Dr. Asma, we speak about a pregnant female because hyperthyroidism is a benign condition. Antithyroid medication, both of them are teratogenic. Both of them have a severe impact on the fetus and the mother. So inshallah, see you later, inshallah, after 2 weeks, inshallah. السلام عليكم ورحمة الله.
شكرا جزيلا، شكرا جزيلا، بارك الله فيك.
شكرا دكتور خالد، ربنا يبارك فيك يا رب.
نشوفكم على خير. السلام عليكم.
الله.